ग्रुप में कोई
नहीं
किसको
300 के आसपास है मिनट 357 इसमें
200 टच कर चुका है अभी, अगर और नहीं
ब्रॉडकास्ट बनाना पड़ेगा फिर।
तो कास्ट करके इंडिविजुअली जाएगा फिर तो ब्रॉडकास्ट में, ग्रुप में नहीं जाएगा।
जो व्हाट्सएप बिजनेस अकाउंट रहता है ना, वो उसकी लिंक है।
देखो
हाँ,
मैम ऐसा
ठीक।
दिखेगा, ठीक है ना। ये शुरू हो गया, ये शुरू हो गया, हमने नाटक शुरू कर दिया अपना।
तो इसमें तो कभी किसी का
कल लिंक पहले भेजो।
इसमें बहुत ही
हाँ,
शक्कर
वैसे
की
ही।
12 बजा देते हैं इन लोग,
मैं डॉक्स में
इंसान
नहीं
बह
थी,
गया और दिखेंगे हम।
नहीं क्योंकि इसमें वर्ड आ रहा है मेरा।
हाँ तो फिर बेस्ट है, अगर वैसे अगर आपको बेस्ट लगे वो मैच करने से आएगा।
हाँ तो मैं ऐसे कर
हाँ वैसे ही कर दे इवन सिंपल।
यूट्यूब वालों का भी व्हाट्सएप अकाउंट है क्या?
यस मैम,
तो उसमें लिंक भेजेंगे ना।
यस मैम। वोशु मैं ना आपको
लिंक और मेल दोनों।
वोशु मैं आपको यूट्यूब का लिंक भेज रही हूँ, 5 मिनट्स बाद सबको भेजना, ग्रुप पे भी मेल पे भी। यशी मैं आपको भी भेजूँ?
मैम उसको भेज दो तो ग्रुप एडमिन बनाया
हाँ
है,
ग्रुप
वही
बन
पोस्ट कर देगी ना।
This is the place from where we are talking. I want you to keep this here as a teleprompter for me.
ओके सर।
I think I can put it here also.
सर विद द हेल्प ऑफ
No need, इतना काफी है। अब तो दिखेगा ना?
देख के बोलेंगे।
हाँ? मैं बिना देख के भी बोल सकता हूँ, but this I have only written right now. Don't miss any point. इतना this is okay.
सर वो यहाँ का वाईफाई सपोर्ट करें
क्या?
इतने लोग ये केबल में चलिए।
हाँ कोई बात नहीं, वो आ जाएगा बोला ना उसको।
तो बोला तो नहीं।
So we have our Wi-Fi is there. My Wi-Fi, not Wi-Fi.
हॉटस्पॉट
Hotspot. My hotspot is there. तो वो तो कोई प्रॉब्लम
A very good morning to our speaker, as sir has joined today now, Dr. Krishnaraj sir. A very good morning, sir. Dean ma'am, good morning.
Very good morning to you. Am I audible?
Yes, sir. Sir, but your voice is a bit low.
Yeah, I'm on full volume here. I have to speak a little louder, I think.
Yes, sir. Yes, sir. Sir, you're audible, very much audible.
Okay.
Very good morning, sir.
Good morning, sir.
Good morning. Just waiting for few more people to join.
Yeah.
So I've asked ma'am to unmute. Hello, good morning, ma'am. Ma'am, actually, I'm asking you to unmute from here. Ma'am, are we audible to you? So ma'am is
नहीं मैं बट आई कुड नॉट हियर लाइक सुनाई नहीं दे रहा था वो प्रॉब्लम थी मुझे बोलना नहीं था ये बाजू में माइक दिख रहा है बोल हाँ
उसको वॉल्यूम चेक करो यहाँ से
म्यूट
Ma'am, now your video is on.
okay I can hear now thank you
Yes, ma'am. We can also hear you, ma'am.
हाँ चलो चलो okay start
Yes, ma'am.
चलो thank you
we can wait for 2-3 more. If more participants join, then we can start. Krishnaraj sir, good morning.
Yeah, good morning, sir.
Yeah, just a couple of minutes we would start.
Yeah, sure.
Yeah, just waiting for, I mean, if anybody would again would like to join in another 2-3 minutes.
Yeah, please.
Yeah. Actually, we are going live on Zoom also. So there are, sorry, live on YouTube. So all undergraduates and all the students have joined over there.
Very nice.
Yeah, because we have just kept this for this platform. Like anybody would like to join later, like we need to have some cushioning. So that's why we have kept it less
Okay.
in the Zoom, but most of the people have joined through.
No problems.
A very warm morning to one and all present here. It's a glad welcome we bring to you all this morning, filled with the desires, hopes, and dreams we all share. We all have virtually gathered here for a webinar on current trends in safety and infection control practices in dental colleges, which is organized by Department of Oral and Maxillofacial Surgery, Chhattisgarh Dental College and Research Institute, Rajnandgaon. We are delighted to extend our pleasure to all the delegates who have joined us. Our respected Dean Ma'am, Dr. Hema Suryavanshi, our Board of Directors, Shri Nemi Chand Parak Sir, our President, Vice President, Shri S.K. Bodhan Sir, Secretary Sanjay Golcha Sir, and all the UGs, undergraduates and postgraduates who have joined us today. So, life is to learn. Hence, let's pray to Goddess Saraswati to achieve salvation through knowledge and rid ourselves of sluggishness and unawareness. So, let's pray and go ahead with Saraswati Vandana. Really sorry. Let's start with Saraswati Vandana. At this time, I would hand over the mic to Dr. Pramod Krishna, Head of the Department of Oral and Maxillofacial Surgery, to gratify the audience. Sir, please.
A very good morning and warm welcome to respected Dean Madam, Board of Directors. I think Golcha sir is there. I don't know if anybody else is there. Staff of our college, all the delegates across the central India and few from other parts of India. We, Department of Oral and Maxillofacial Surgery, Chhattisgarh Dental College and Research Institute, take this privilege of organizing webinar on current trends in safety and infection control practices in dental colleges, wherein we would be able to sensitize the upcoming dental surgeons and specialists, dental surgeons, on need for having a protocol in infection control for the safety of patients as well as staff of the dental college. The speaker is Dr. Professor Krishnaraj Ganesh Narayan, who is an eminent person with various credentials related to the field. And I thank him for accepting our invitation. Thank you, sir. I hope and wish you all to have an enlightened session. Without wasting much of time, I hand over the podium. Have a nice day.
Thank you, sir. Moving ahead, with pleasure, I would like to invite our Dean Ma'am, Dr. Hema Suryavanshi, to illumine us with her alluring thoughts. Ma'am, over to you.
Good morning, everyone. Am I audible?
Yes, ma'am, you're audible.
Yes.
I welcome all our board of directors. I welcome Dr. Krishnaraj Ganesh Narayan, who is speaker for today. And I was just going through his CV. It's a vast CV, and like he has hold in many fields, like in whether it is in clinical, whether it is in academics, whether he's a motivational speaker also, and he conducts courses also, and he has done PhD from our subject, that is oral biology, from New Jersey. So I welcome you, sir. I congratulate you for your vast academic experience. I welcome all our faculties. I welcome the faculties from all over India, and I welcome all the students for this webinar organized by Department of Oral Surgery. I think this is the second webinar organized by Department of Oral Surgery. I congratulate Dr. Pramod Krishna sir and his team for this organizing this webinar. Krishnaraj Ganesh Narayan sir will be speaking on current trends in safety and infection control practices in dental colleges. But while going through his CV, I could make it out that we will keep on inviting him again and again. And I request you, sir, please accept our invitation whenever we ask for it. And please provide us your knowledge whenever you can provide it to us. I was having this topic in mind since long, because this is of importance for our college point of view also, from routine biomedical safety point of view, and from our students point of view, our faculty point of view, and moreover, like in now in COVID-19 arena, this became very important. So I am happy that Dr. Krishnaraj Ganesh Narayan sir has accepted our invitation to speak on this topic. And I congratulate once again the Department of Oral and Maxillofacial Surgery for organizing this webinar. Keep it, sir, Dr. Pramod Krishna sir, and thank you. Over to you, Palak.
Thank you, ma'am. Thank you very much. You warmed our hearts. Now, with no delay, I would like to delightfully welcome our today's speaker, Professor Dr. Krishnaraj Ganesh Narayan, sir.
Hi, Palak.
Professor Dr. Krishnaraj Ganesh Narayan, sir. Sir is accomplished with Bachelor's of Dental Surgery degree from VS Dental College, Bangalore in 1999. Sir is specialized in periodontics and has attained Master's in Dental Surgery degree from SDM College of Dental Sciences in 2004. He is certified in HIPAA regulations, UMDNJ, and also in infection control, approved by the New York State Department of Health, USA. He is a full scholarship PhD holder in oral biology from the University of Medicine and Dentistry, New Jersey, USA in 2012. Sir holds a provisional patent on the use of salivary protein as an antimicrobial agent. He is a founder of two elite groups of Delta Dental Care and Delta Dental Academy, provisional dent program, dental treatment, and dental courses worldwide. Sir is streaming a quality assurance program for several clinics and hospitals, focusing on training and monitoring clinical safety and infection control. He, owing excellent communicative skills, has completed 100 workshops on practice, management, and training, and is an invited motivational speaker in several national and international conferences. Sir, we are honored to have you. Sir, we are eager to hear you today. So now I hand over the virtual dice to you.
Thank you, Palak.
Pleasure,
Let me
sir.
share my screen. Yeah. Share. Right. Is my screen visible?
Yes, sir, it is visible, sir.
Yeah. A very good morning to all of you. Good morning, Palak. Dean Madam, very good morning to you. Pramod sir, very good morning. Firstly, thanks for such a wonderful introduction. Among all the classes or courses that I have conducted or workshops that I have taken, this has so far been the best introduction I've got. The problem with such kind of introduction is you already set the bar high, so now I have to motivate. I have to speak something that is good. Otherwise, they'll say, "Arey, kisko bulaya yaar?" Anyway, so anyway, I'm very grateful for this opportunity. One thing, as age advances, we realize that accomplishments don't matter. We have to be grateful for every single day that we are alive. We have to be grateful for every opportunity that comes our way. And we all as dentists are, of course, we are all in here in dentistry, doing practice, earning money, running a successful business or trying to run a business. But at the end of the day, we are accountable. And that's one thing that we have realized is we are accountable for tomorrow. When you start your own practices, you are accountable to your patients. You are accountable to the other people working in the organization. So if you have a front office, this is for the students and also for the faculty. If you have your own clinic, or if you're working in a college as a professor, as a principal, as a HOD, as a professor, assistant professor, readers, even as a private practitioner, you all have responsibilities. We all have responsibilities towards our patients. We have responsibilities towards our co-workers. We have responsibility towards the other people in the organization whom we are working for. Dentistry is not as safe as what we would like to think. Dentists have always been exposed to various infections, various infectious agents since time immemorial. And dentistry, is not new to viruses and bacteria. As dentists, we have always been exposed. So a certain amount of standard precautions has always been there in our psyche. Unfortunately, because of this pandemic, situation has worsened, and a lot of fear has set in. This fear, I know even today there are so many practices, there are still not opened. There are so many dentists, especially with comorbidities like diabetes, with hypertension. Some people who are a little older patients, older dentists, they have still not begun their practice. So the idea of running these kind of courses, running the safety and infection control webinars and talks is to sensitize people on what we can do, how to protect ourselves and our patients. At the same time, not to be scared, not to be scared. And you have to continue working the way we have worked before. Nothing is going to happen if we follow these certain key aspects of infection control. And it's nothing to do with COVID, nothing to do with anything. We have been always exposed to so many things. So we want to focus a little bit on today. I must also congratulate the entire college and the management to take this foresight, because usually what happens, dental colleges responsibility is they get the students, they run the courses, they finish their schedule of topics, whatever they have to teach as far as the subjects are concerned, and they finish the graduation. No, a good college will always look upon how the students are functioning after they graduate. Whether the students who are graduating from dental colleges today are equipped to start their own practice. Now, from that perspective, I congratulate the college, Chhattisgarh Dental College, to take this vision and foresight to prepare the students in the real world of dentistry. When you come outside, the difference between what you see in your college and what you actually see when you start your own practices should be as less as possible. And following these infection control practices will definitely take us a step closer to what we ideally like to achieve in practice. I'm assuming that a lot of the audience here are students, and usually when I take courses, I have at least some 80, 100 or 200 people in front of me. So it's easier to find out who's sleeping, who's awake, and where I need to crack a joke, where I need to liven up the audience. Unfortunately, now if somebody else sees me, I seem like a fool sitting in front of a screen and talking to a screen. And all your people are muted their video. So I don't know whom I'm speaking to, but forgive me if my lecture. And usually what happens, infection control is not a very interesting topic. It's always a little dry topic. So to retain the interest, I'd request if people can switch on their video so that I can know whom I'm talking to. See, first leadership starts from there. Leadership starts by setting an example. So the principal is the first person to switch on their video, and now they have, she has shown the way. Thank you, madam. If nobody else, at least I can see your smiling face and I can talk to you. Anyway, without further ado, just want to go into a little basics of infection control. This infection control topic is going to be a huge, it's about a 8-hour topic, 2-day course, but we are trying to fit it into about 1 hour, 1.5 hours of 2 sessions of 45 minutes each. The fundamental philosophy here is, we all take an oath as dentists where we will try and do the best to our patients, right? Do no harm. Do no harm. This is the oath we take. Even if we are not doing any benefit to our patients, we should not do any harm. So we have to realize what harm we can do. One, obviously financial harm, that we are taking money from the patients, a lot of money. The other harm that is obviously that we are exposing the patients to a lot of risk and exposing ourselves and our team. So before we get into how to prevent this infection, we have to understand what is the risk of infection that we have. Obviously, we know that infection in the dental clinics can spread. There are a lot of cases that have been filed against dentists, cases pending in the High Court also, on patients who have sued the dentists for developing some infections. Now, we have to realize that in a dental clinic, the infection can spread from the doctor to the patient, right? The infection can spread from the patient to the doctor. The infection can spread from the doctor to the team or from the patient to the team. the infection can spread from one patient to the next patient. And infection can spread from the patient to the community at large, or from the dentist or the dental team to the community at large. So the possibility of spread of infection is huge. From, you can get infected, the patients can get infected, their families, and then the community at large can get infected. So we have a moral responsibility to stop or to break this chain. What this chain encompasses is obviously the infectious agent. It could be a coronavirus, it could be hepatitis B, it could be HIV, it could be tuberculosis, it could be any of these infectious agents, right? It needs a reservoir. Obviously, without a reservoir, the infection will not progress. It needs a portal of exit. Suppose if I am infected, if I want to infect you, then there has to be a way where the agent has to exit my body and enter your body. There has to be a mode of transmission. So either it can be through aerosol, it can be through the air, it can be through blood, it can be through any of the other secretions. So there is a mode of transmission. Then there is a portal of entry. The portal of entry could be what? When you breathe the same air, it could be the air that you're breathing. Or if a patient's probe is there, you use the probe on the particular patient which has got an HIV in it or hepatitis B in it, and while washing the instruments, if you poke yourself, that's a portal of entry. So there has to be a portal of entry. And then finally, what is important is also we need to have a susceptible host. And what I mean by susceptible host is, chalo aap aur main dono gaye, we go to a restaurant, we have 2 idlis. Okay, you are all right, but I get a loose motion. So person to person, the body also differs. So you need a susceptible host at the end of the day to have this kind of infection. So today we're going to talk a little bit about what infection control means and what are the different programs. And we have divided it into 2 sessions. The first session will be focusing on the infection control aspects, where we will be talking about hand hygiene. I want to spend a lot of time on that. PPE, today everybody is doing PPP only across the country. So we're going to discuss what are the elements of PPE, how do you make the right choice, and what is the decision of what kind of PPE you're supposed to use. We are talking about sterilization and disinfection, some protocols that we need to follow. Environmental disinfection is for those areas where disinfection is not, sterilization is not possible. How do we handle those areas? We're going to talk a little bit about immunization and about how bloodborne pathogens play a significant role. We're going to talk a little bit more about disposal of biomedical waste as well, right? So these are for some of the aspects that we are going to discuss. So first we'll speak about hand hygiene. You know, in India, we always say namaste. The term we're using namaste with folded hands has always been highly hygienic practice. From a moral perspective, psychological perspective, even spiritual perspective, today there are various sadgurus and gurus who are also saying that why shaking hands with others is not that good, because you imbibe some of the vibrations, the negative vibrations and all that. But more importantly, we are talking about the infection control perspective. WHO has said that 90% of cross contamination that happens because of handshakes. So if you do a proper hand hygiene, cross contamination chances reduce by 90%. Right? When you are using a proper hand hygiene, it reduces antimicrobial resistance that occurs over a period. These are reviewed clinical trials which have proved the fact that hand hygiene is the single most effective method of preventing cross contamination. Many of the people, whenever I conduct the course, I ask randomly people to show how they wash their hands. Usually 90% of the people, they don't know how to wash hands. So today we'll be discussing when to wash hands, how to wash hands, why to wash hands, and things like that. Now, usually for students, I recommend, even dentists, when you're entering the clinic, the first thing after you enter the clinic, you wash your hands with soap and water. Now, when you're washing your hands, there are 2 components to it. You can use a soap and you can use this antimicrobial or alcohol-based hand rub. So there is a hand wash and there is a hand rub. There are 2 things. When do you use a hand wash? When do you use a hand rub? Usually, when you enter the clinic in the morning, the first thing, wash your hands with soap and water. After finishing every patient, when you remove your gloves, all this glove powder and all that is there, wash your hands with soap and water. When you go for lunch, before going for lunch and coming back from lunch, wash your hands with soap and water. And finally, before leaving the clinic in the evening or in the night, it is important to wash your hands with soap and water. These are must and should times where soap and water have to be used. The other times we can use just a hand rub. How to make a decision whether to use a hand wash or a hand rub is observe your hands. If your hands are visibly dirty, if your hands are visibly soiled or moist, soiled, then always prefer to use a soap. If you find your hands are otherwise clean, you can't find anything wrong, then a simple hand rub can be sufficient. Also remember that you cannot use a hand rub on wet hands. So many times I have seen students, they wash their hands, they don't even wait for the hands to get dry, or they don't dry their hands and straight away they use the alcohol hand rub. Alcohol hand rub will be absolutely ineffective when it is used on wet hands. So make sure when you're using a hand rub, your hands are dry. Now, why there are some steps. We have some 7 steps of hand washing. Now, why these 7 steps are created is, there was a study which found out which part of the hand is missed when we do the hand wash. When we do the hand wash, which areas of the hands we routinely miss out. So if you see this picture, there are areas marked in red. These areas which are marked in red are areas where the hand wash is not properly done, even when you wash your hands properly. There are areas marked in orange which are often missed, and the areas marked in yellow are very less often missed, means most of the time they get washed. So if you look at the areas which are most often missed, you can see that there is a thumb involved, the tip of fingers are involved. If you see the area between the fingers, they are not cleaned, and the fate lines. So these lines are not cleaned. These areas are not clean. So we have a system where when you wash your hands first, following these 7 steps, they will ensure that all the parts of the hand are properly washed. The same steps are applicable when you are using a hand rub as well, or a hand wash, right? So these are the WHO given steps. 7 or 8 steps are there. First thing that you need to do is wet your hands. Okay, don't directly take soap on your dry hands. First thing you have to do is wet your hands. After your hands are wet, one pump. When you use a liquid soap, always I also tell one thing is use a liquid soap. Liquid soap is always much better than a bar soap. And a lot of times I have seen the bar soap is dirtier, so you feel actually dirty to use that bar soap. So preferably, my advice to colleges, to everybody is, in the departments, try to have liquid soap, antimicrobial liquid soap. Now, when your hands are wet, take one pump. So once you pump it, they are proportioned in such a way that every pump will yield 1.5 ml. So the stocks also you can monitor that how much of hand wash is supposed to be used. So in a day, if you are seeing, if there are 10 students or 20 students in a department, and they are totally, you have 60 or 70 patients who are visiting, each patient, the doctor has to wash the hands before and after. So 3 ml will be consumed by one particular student. So if there are 20 students and if there are 70 patients, so there are roughly about 200 ml, 150 to 200 ml of the hand wash per department per day should be consumed. If it is under consumed, it means the students are not washing their hands adequately. If it is over consumed, it means some wastage or some pilferage is happening. So these are some administrative controls also that can be done by the college to see whether the materials are being used properly or they are not. But once you use the pump, 1.5 ml of the soap is dispensed onto the palm. Now we have 7 steps. The first step is this: you have to wash your hands, the face of you have to do the first step. The second step is the back of the hands. The back of the hands need to be washed. Third step is the area between the fingers. 3. The fourth step is the tip of the fingers and the nails on the both sides. This is step number 4. So step number 5, this is step number 5, where you wash the palms. And step number 6 is you wash the thumb. And step number 7 is you wash the wrist, you wipe the wrist. So make sure your watch, everything is out when you're washing it. These 7 steps, 1, 2, 3, 4, 5, 6, and 7. These 7 steps of hand hygiene are extremely important. Usually, whenever I take a course, I will randomly ask people, you show me step 1, you show me step 3, and step 5. So I want everybody to do it along with me. Do it along with me. I want the students who are all watching this, even everybody, whoever wants to do it, but do it with me. Let's do step 1, step 2, step 3, step 3, step 4, step 5, step 6, and step 7. So 1, 2, 3, 4, 5, 6, 7. So this, even if I wake you up at 2 o'clock in the night and ask you the 7 steps of hygiene, you should be able to do it. And take it up as your responsibility that your parents in your house, your friends, your brothers, your sisters, your husband, your wife, your children, you teach at least 4 or 5 people to follow these 7 steps. Today, in our country, today we are trying to come out of this pandemic situation where washing hands properly is the key. And we have a moral and social responsibility as doctors to educate not only our students, not only our thing, but everybody in our surroundings, in our neighborhood. Everybody has to follow this proper hand hygiene protocol. This will help us save from not only corona. Tomorrow, if any other pandemic also comes, washing hands is going to save a lot of lives. Washing hands is going to save lives. So please follow this very, very sincerely. Please learn this properly and educate yourself and all, at least 10 people around you. You please make sure that this hand washing is done. Right? So the same protocol is for alcohol hand rub also. So after you finish the hand wash, the second step is to do the hand rub in the same manner. Now, people many times I have seen after washing using their hands with hand rub, then they will take one tissue and wipe it. Please don't do that. Once you use the hand rub, let it dry by itself. Now, a thing for you staff and thing for you faculty is, I always tell that there should be a monitoring mechanism. क्या इंडिया में बोलने से काम नहीं चलता है. We have to make sure that things are happening, so we need to monitor. अब monitor कैसा करना? You have to identify how many opportunities are there for hand hygiene. कितनी बार धोना चाहिए और actual में कितनी बार हो रहा है. So department में staff when they are sitting, observe the students. Observe whether they are washing their hands properly. Observe whether they are doing the 7 steps or not. Observe whether they are washing hands before, whether they are washing hands after. So opportunities for hand hygiene versus actual amount of hand hygiene. This is the staff responsibility to make sure that it is happening. Then you do a random monitoring and then there are scoring patterns. I have some recommendations towards which I will be sharing for colleges towards the end on how to successfully implement the infection control program in your college. So I will say some points also which are important. Now, after hand hygiene, the second thing that we are going to discuss is about PPE. Now, in PPE, what do you mean by PPE? Is personal protective equipment. It's not personal, it's personnel. Personnel means the people. So personal protective equipment, what all comes under this is the PPE gown. There are masks, protective eyewear, shields, gloves, and all that. And obviously some head cap as well. Now, PPE gowns, a lot of times, nowadays, so many gowns are available. There is 40 GSM, 50 GSM, 70, 90, 120. Now, many times I keep getting asked this question in all my webinars is, sir, what GSM should I use? Is 40 enough, 50 enough? What should be the actual GSM? And whether ये एक बार हमने जो PPE पहना उसको हर patient के बाद whether we have to dispose it or can we reuse this PPE? Some people are reusing the PPE and not telling it. Some people are hiding it, thinking that it is a wrong thing. Now, I want to make the matter simple here. So I want to come with certain facts. Now, what the World Health Organization is there in this chart is a little busy chart, but I want you to just focus on 2 things. In the bottom, you see the basis weight. It says 49 GSM, 49 GSM, 41 GSM, 69, 63, 63, 65. if you see the bottom, just bottom is whole suit performance, उसके ऊपर है seam strength, उसके ऊपर है basis weight. The basis weight is your GSM. And if you look at some of these green columns on top, which means they are acceptable. What I'm trying to tell you is whether you are going with 40 GSM, 50 GSM, 60 GSM, 90 GSM, 120 GSM, all of them are effective. All of them are effective against virus. There is no virus or any bacteria or anything that penetrates. What is important here is not the GSM count. What is important here is whether your PPE is laminated or is not laminated. Now, what do you mean by lamination is there is a thin coat, plastic coat, either on the outer surface or inner surface. There is a coat which acts as a barrier, it acts as a physical barrier. How do you check it? आपने PPE पहना, उसके ऊपर से few drops of water you put and then see whether the inside is getting wet or it's not getting wet. So if you have a laminated PPE and even if it is 40-50 GSM, trust me, आप 80 GSM वाला PPE पहन के 20 मिनट रूट कैनाल कर लो एक बार, मान गए आप. I mean, you cannot work if you're wearing 90 GSM or 100 GSM PPE and you sit for 1.5 to 2 hours doing one procedure, 2 किलो आपका वैसे ही कम हो जाएगा. So please don't use it as a weight reduction exercise. But I'm trying to say is what is important in a PPE is whether it is laminated. So when you buy, there are many PPEs available in the market. So please ensure that the PPE that you buy is laminated one, and that is more than sufficient. Whether it is disposable or reusable. Now, ये बहुत सारे, if you can see here, there are many types of PPE kits available. Some make you, I mean, sometimes when you wear all these and you call the patient in for a diagnostic checkup, the patient will get a heart attack there only by seeing कि क्या भाई ऑपरेशन करने वाले इधर करेंगे मैडम ओटी में करेंगे. तो our idea is not to scare, our idea is to protect ourselves, but let's not go overboard. And some people I have seen in some clinics use this कि मैं इतना पहना तो the patient should feel I'm doing a big procedure, so I will add one more zero in my treatment cost. So the whenever we are using a particular PPE, I usually have 2 sets of PPE. One is just a random. Now what I do is I don't wear these clothes in the clinic. Everybody I tell, when you enter the clinical premise, change from your normal clothes and wear scrubs. Scrubs is like not like OT or whatever, it is a uniform. The idea is it will reduce the amount of bacterial exposure that your family suffers because of you from your clothes. So make sure that whatever clothes you are wearing from the house to the college, you change it and get into your scrubs. After wearing the scrubs, when you are just doing a diagnosis for a patient, you don't even need to wear a PPE. There is no need to wear a PPE if you are doing only diagnostic checkup. You can wear your face shield if you want, you wear your mask, you wear gloves, and you wear an apron. That is more than enough. You do not have to wear a PPE just to examine the case if you're doing a consultation. When you're doing a non-aerosol generating procedure, if you're doing a crown cementation, or if you're doing a hand scaling, or if you're doing something, wear a simple PPE, which is obviously laminated. Any PPE has to be laminated. But whenever you are doing a aerosol generating procedure, I recommend that you wear the full PPE kit with the hood. So that will protect you against any spray, aerosol spatter or the spray that comes. So this is regarding the PPEs. Now mask. Now the India mein the next biggest business today is mask. So there are hundreds and thousands of companies already into the mask. Which mask do you buy? I find it very funny that I go on the road and I find certain people wearing face shield, wearing eyewear and wearing N95 mask and walking on the road. These masks are not meant for general public. N95 masks are only for medical professionals, are only for people working treating patients. So my advice always to the general public is don't have to go for all these masks. But as a student, as a dental practitioner, whenever you are treating patients, make sure you are wearing an N95 mask. The problem today is, how do you know whether the mask you are wearing is N95 or not? Sabhi mein chhapa rehta hai N95. How do you determine whether it is a fake N95 or a real N95? Nobody knows. Now here is some things how you can know. There are 3 types of masks. Okay. Now all these N series, N95, N99, they are all based from US standards of NIOSH. The NIOSH is a National Institute of Occupational Safety Hazards that has published these based on the thing. Actually, these masks are not meant for dental. The masks basically come in 3 types: N, P, and R. N is non-resistant, P is partially resistant, R is fully resistant. Now, resistance to what? Resistance to oil. So they are basically for industrial purposes, because and for oil in oil and gas explorations and things like that. Since we are working in the medical field, we don't need partial resistance or we don't need complete resistance. So we are using the non-resistance one, which signifies the N. What does this 95, 99, 100, all these numbers indicate? What percentage of bacteria or viruses get filtered? What percentage of bacteria gets filtered when you wear the mask? So an N95 mask means 95% of the bacteria. Now N99 means 99%. N100 means 100% of the bacteria. Now, if you wear why N95? Why not N99? Why not N100? One thing, though, it is not available. Second thing, you wear it, you can't breathe. So N95 is sufficient for us. Second point is, when you look at an N95 mask, there are many N95 with single loop. Okay? There is one loop from top, one loop in the bottom. These are not N95 masks. Anybody who sells you an N95 mask saying that this band comes from here to here, is not. It is absolutely wrong. Any N95 mask should have 2 loops. There should be a top loop and there should be a bottom loop. Unless and until there is a top and a bottom loop, take it from me, it is not a registered proper N95 mask. Point number 2, whenever you are looking at a mask, there is some exterior markings on it. Check these markings. There is a particular number. These numbers will be there, model number will be there, then there will be the batch number, everything will be written, right? And the name of the company. Now, if you want to know whether this company is genuine N95 mask maker or not, there is a website called cdc.org. You go to CDC website and there is a list of companies that have safety tested N95 masks. Any mask anywhere in the world that can claim to be N95 have to get registered themselves with the CDC website. So if you go to the CDC website, type in your company's name which you have bought the mask, you can clearly check whether that mask is actually a fake N95 or a genuine N95. The other thing is you have to have a face seal fit. So you have to make sure that it fits on the top, it fits on the bottom and things like that. So these are, now there are some other masks, they look like a Batman movie mein, there is one villain who wears that. So many people wear those also, thinking that they are protected more. They, apart from looking funny, they don't serve any additional purpose. They are all European standards. They are called FFP1, FFP2, FFP3 and things like that. These are respirators. The respirators have got nothing to do with coronavirus. So unfortunately, people don't understand the fundamental differences between these. There is some cartridge inside it. It's basically like a HEPA filter. I'm against anything that has a filter in it, for the pure fundamental reason that anything that is a filter will accumulate dirt, will accumulate dust. So that will act as a source and a nidus for bacteria or viruses to grow, multiply, and then start spread, become super spreader. So unless you keep changing the cartridge very often, I'm not in favor of anything that has a filter. So that is my personal opinion. I'm not forcing it on anybody. There are other masks called in China one, they're called KN95. Abhi to bhul jao, koi to aayega nahi wahan se. And then from the Japanese point, there is the standardization called DS. So there are some DS masks also available, but they're very expensive. But not that it is a superior quality or anything. Japanese put a price on their labor. So their work is good, their prices are like that. But for us, A good N95 mask when we are using should be sufficient. Can you reuse a mask? Many times I get asked this question. Sir, अभी mask अभी पहना तो ग्लिकमैन के अंदर रख सकते हैं क्या? और can we use it on 3 days or 4 days or 10 days? जब तक फटता नहीं है तब तक mask use करेंगे. Now there is no such rule that you have to throw the N95 mask after every use. You can reuse it. There is no doubt about it. Now, when you reuse it, there are certain precautions that you need to take. When you are using these N95 masks for a consultation purpose, for a non-aerosol generating purpose, these masks can be reused to the next patient. But when you are working on aerosols, so there is a high risk that some of these aerosols which contain these viruses are settled on the mask. So I will advise buy 10 masks and label them. Buy 10 masks, label them. Colleges maybe 12 masks. Student buy 12 masks each. So what I will recommend is label them M1, M2. That is Monday first half, Monday second half. T1, TU1, TU2, Tuesday first half, Tuesday second half. Wednesday first half, Wednesday second half. Thursday first half, Thursday second half. So when you use your mask on first session on Monday, next time you use it in next M1. 12 mask रखो. साथ में नहीं रखना. No point if you are keeping all the masks together. After use, you are putting it back together. Your viruses on M1 will get to M2 or to T1. Keep it in different places. Keep it in different places. So hang the mask, and if it is you, alternatively, you have some ovens which are available now with UV light. Expose them to UVC light. Make sure what kind of UV light is there. UVC light, that's a different discussion. આજકાલ there are a lot of materials available, UV light and all that. Whether it is effective or not is a big question because UVC does not have a distance of action greater than 25 centimeters. So if your mask is kept 25 centimeters away from the UV light source or greater than 30 centimeters away from the UV light, there is no bactericidal or germicidal effect that comes because of the UVC. Secondly is the UV light decays over a period of time. So you may still get the blue light, but अंदर कुछ UV नहीं होगा. So you have to check constantly with the UV meter. So these are expensive propositions. Whether it is effective or not is different, but you can use them. So you can reuse the masks, keep a multiple masks and keep it for different sessions. That will reduce it. Next, we speak about eyewear and face shield. This is one thing I always recommend people to wear. Always recommend, especially dentists have to wear these. And I will request all the staff, HODs and the faculty members to make sure that students invest in a good face shield. Not those cheap ones, good face shields. They let them reuse it. You can reuse it. Only thing they have to make sure is that they do not use any surgical spirit or any sort of alcohol-based hand rub to disinfect the face shield. Because once you use any sort of alcohol on the plastic, it becomes opaque. So when you are using a face shield, make sure you get those long face shields that cover up to the below your neck, and there's that comes with the lever on top that you can lift up and down. Those ones are relatively comfortable. They're especially useful for students and for people who wearing glasses, where they cannot use another protective eyewear over their glasses. For them, face shields are definitely very, very important. Soft tissue shield around the eyes is also important. This is not only because of corona, but I've had treated many cases where calculus flies, filling material fly and goes into the eye. So it's always eye protection as far as infection control. The ocular mucosa is one of the most susceptible mucosas. And as of now, mode of spread, there have not been many studies, but I'm sure if you do a proper study, ocular mucosa will act as a reservoir and can act as a portal of entry for many bacteria or many viruses. So eyewear and face shield is extremely important. Please make sure. And also along with that, a proper head cap. A head cap should cover your hair fully, which cover all the way till here, till no hair should left unexposed. I have gone to many clinics where people will wear head cap only till here, and they'll be a little bit in the side, thoda Robin Hood jaisa, and then they're working on patients, and especially ladies will have long hair, and patient उधर मुंह खोल के ऐसा कर रहा है, बाल मुंह में गिर रहे हैं patient doctor के. These are not good practices. So make sure that the students are wearing a proper head cap as well. It's very important. Gloves, now again, this is just one a video. If you want, we can go through this, otherwise not. It's just how to wear gloves. There are many types of gloves available. You have latex gloves, you have non-latex gloves, then you have disposable gloves, you have sterile surgical gloves. When do we use each of these is important. When we are doing any sort of investigations or examination, a simple gloves, regular gloves is sufficient. But whenever we are doing an invasive procedure, there a sterile surgical gloves is must. Now, what defines a invasive procedure differs from councils to councils, IDAs to IDAs, or countries to countries. If you go to UK, even extraction of teeth is considered non-invasive. That is a transalveolar extraction. If you're, if you're closed extraction. If you're doing an impaction, yes, that is considered as a open extraction is considered as an invasive procedure. But even a regular extraction is considered as a non-invasive procedure. But for us, anything to where there is blood on our hands, we feel it is an invasive procedure. So I leave it to the departments to decide what is invasive, what is non-invasive. But if an invasive procedure is done, then definitely we have to use a sterile surgical gloves. Otherwise, disposable gloves. No question of reusing gloves here, for simple reason that many people feel if we autoclave the gloves, it becomes free of bacteria. Why can't we reuse them? The latex matrix, which is once you autoclave it, completely gets destroyed. So it no longer offers the protection that it does before. So you cannot autoclave gloves. Some people develop allergy to latex. So nowadays we have non-latex gloves like nitrile gloves available. Nowadays it's become cheaper. Earlier it used to be very expensive. Now even nitrile gloves are more or less the same cost. Maybe on 20-30 rupees for a box will be the difference, but nitrile gloves are available. Especially certain kind of some prosthodontists if here will agree with me, if you are doing certain treatments like putty and all that, if you're taking putty impressions, always we prefer to wear nitrile gloves or vinyl gloves. So similarly, if you have allergy to latex, then you have powdered versus non-powdered. Some people are allergic to the powder. They develop contact dermatitis and things like that. Encourage students to use hand creams. Aloe vera is there, neem, so many hand creams are there. It is better they use it now, because children, they will not realize it today. When they come to our age, that's when they realize that after years of neglect, the hand is spoiled. So take these safety precautions from before only. Protect yourself, protect your hands, and yeah. So we can go through a small.
This video was produced by the Clinical Skills Lab, University
I don't know
of
if it's audible.
The University of Bristol. The video describes one correct way of. Every student should check with their university whether they have a. Note that gloves are often made of latex. Before putting on sterile gloves, your hands should have been adequately cleaned and disinfected. First, check the packaging for damage. If the packaging is damaged, the gloves are no longer sterile. Sterile gloves are not like other disposable gloves, where the sizes are divided into small, medium, and large, but are labelled from 5.5 to 9. Sterile gloves are double wrapped. First, open the outer packaging and place the gloves in their inner packaging on a sterile surface without touching them. Open out the paper packaging, making sure not to contaminate the gloves. Press the edges of the paper down so that they lie flat. The glove for the left hand is on the left, and the glove for the right hand is on the right when the fingers are pointing away from you. The cuffs are turned inside out. Hold the averted end of the right glove in your left hand. Slide your right hand into the glove without touching your left hand. Use your gloved right fingers to reach under the cuff of the left glove. With the fingers of your right hand, hold the left glove so your left hand can slide into the glove. Now you can pull the cuffs down over your wrists and adjust the position of the gloves. It is essential to ensure that no skin is touched with the outside of the sterile gloves.
Okay. So this is about the gloving technique. I'm sure most of you know it, but sometimes we tend to overlook. And the point is, we will do all this, and then our mobile will ring, and then we will put our hand into the mobile and say, "Hello, हाँ आ रहा हूँ." So fundamental mistake done by a lot of practitioners, students, everything included is when we are students, we always do the right thing. Once we graduate and start become practitioners, we get the confidence that no disease will affect us. So we start overlooking and we start ignoring some of the things that we learned during college time. So my sincere advice to all you students is remember what you're doing today, right? Never let go of the practices that you're following in colleges, because colleges teach you the right thing. Practice always teaches you the shortcut methods. Colleges will teach you the right thing. So at some point where you have to make a decision, where you have to make a choice, always follow whatever is the right thing. Do the right thing always. Now next we speak about instrument sterilization and disinfection. We are basically following the Spalding's classification of instruments: critical, semi-critical, and non-critical. So wherever possible, autoclaving is the best way to sterilize an equipment. So now in this sterilization, my sincere advice to colleges, because we are addressing a college platform, my sincere advice, every college should consider the possibility of opening a CSSD. We have successfully implemented in 2 or 3 colleges where I was fortunate enough to be a part of that team. CSSD is nothing but Central Sterile Supplies Department, which caters to the sterilization needs of the entire college. So what happens is, every department, if you have a separate sterilization room, there is more possibility of doing mistakes. So if you want to reduce the mistakes in sterilization, it may be worthwhile to invest in a CSSD where equipments and instruments, instruments from all the departments are pulled into the CSSD. And in the CSSD, we have 2-3 full-time staff working who receive the instruments, document it, then go through the process of sterilizing. And then after the sterilization is complete, they hand it back to the departments. The students are supposed to deposit their instruments at the beginning of 3rd year and take it back only at the end of internship. Now, each student can label their own instruments with the aerotar or something on the instrument, and that comes back to the same student. If you have a proper coding process, department-wise coding process, it is possible to have the same instruments retained. Right now, the students usually what we tell is they waive off the right to the instruments after they finish their internship. So the students have to leave back their instruments in the college and they go. Some of these instruments can be reused for the next generation of students, and some of these instruments, when they are broken or things like that, can be replaced by if you have some additional supply. But it is without incurring a lot of cost. It is possible to have a sterile supplies department in every college. Now, there are 2 ways of doing it. One is you buy a new autoclave, like a big one. You get an industrial autoclave, maybe a 400 liter or a 300 liter will be sufficient to cater the needs of a dental college. You can have 1 or 2 if the college is ready to invest. If the college is not ready to invest, you can pull out the autoclaves from all the departments. All the departments' autoclave can be pulled into one place, and then department specific autoclaving can be done in that particular area, in that particular department. So I'm very happy to go on further, but due to paucity of time, if you are interested, you can always ask me. I can provide my suggestions to how to set up the CSSD in the department. The idea is, once we did the CSSD setup, we found that the number of mistakes happening in the sterilization became very less. we were better able to control the sterilization processes. Third is the post-operative infection rate. Now, how do you assess whether your program is successful or not? Your re-RCTs that occur, your recurrence of infections that come, they reduce drastically over a period of time. What, especially in colleges, what happens is postgraduate students, if they are there, if they are doing a procedure, the time taken by the PGs or the undergraduate students is much longer than a trained or an experienced doctor. So the possibility of infection becomes very high. Post-op infection becomes high. So in such situations, having a CSSD will definitely reduce the risk of post-operative infections in patients. So we actually documented it over a 1 year's period, and we found that CSSD makes a lot of sense. So some of the things is that we have a separate entry for a sterilization room, separate exit. So the entry and exit should be two different areas. In the sterilization room, basically we divide it into two parts. We have a dirty area and you have a clean area. So instruments, when they come, they should go into the dirty area. Once they move into the clean area, they should never come back again into the dirty area. So have a physical division. So we kind of make like splash guards. Splash guards are transparent acrylic sheets that you can just keep next to the sink, and you can use it as a room divider. So if you have a bench, you can divide that bench into a dirty area and you can clean area with the help of one or two of these splash guards. So splash guards means what happens is when you do the disinfection, you wash the instruments, all the dirty water that splashes out does not come into the other areas to protect that area. So divide it into 3 zones. We have one zone called disinfection zone. Then you have another zone called sealing and packaging. And then the third zone is the sterile supplies zone. So what happens in the disinfection area, what my recommendation is, usually students will get their instruments. Now what happens, every student, I don't know in dental colleges, every student will go wash their instruments separately. What we have implemented is if there are 10 students or 8 students or 10 students in a particular department, in a particular posting, and the posting is for 20 days. So every student has to wash the instruments of all the students in that department. So if Monday is an instrument washing responsibility of student A. So all the students, after they finish, they'll put it into the decontamination area. Student 1 has to wash the instruments of everybody. Next day, student 2 has to wash the instruments of everybody. Next day, student 3 has to wash the instrument. You obviously have some staff also. Some assistant or department dental assistant is there in every department. They can do it also, but I would prefer that the students do it so that they get a hands-on experience on how to wash an instrument. Tomorrow it will be helpful for the clinic, their own clinics. So in the instrument decontamination, you have a small tub in the sink. You place the thing in the instruments inside the tub. You fill up the tub with water. Let the instruments first soak in the tub for about 15 to 20 minutes. Then the student or the person, whoever is washing it, have to wear utility gloves, not the latex gloves or the regular gloves. They have to wear heavy duty utility gloves which fits them. Not most today, what happened, 90% of the people joining are girls. Those days we had a lot of boys. So now everybody will fit into small glove only. So based on whatever size, you can buy one small and one medium glove, and the students have to use the gloves that correctly fits them, then scrub the instruments. So once they scrub the instruments, use your regular detergent or whatever, and with a spoon, with a toothbrush, you can just, they can scrub the instruments. And there are 2 steps to it. One is first scrubbing. The second step is rinsing. So after scrubbing, they have to rinse it again. So this is the step 3. You have to rinse the scrubbed instruments under clean running water. So this is occurs in one separate zone or dirty zone called as instrument decontamination. Once the instruments are decontaminated, they move to the second area. I request all the departments to also go back, not from putting those green pouches where students put their instrument inside, roll it and tie it and keep it for autoclaving. I think this was how it used to be for us when we were in dental school. But now I hope things have changed. Sealing and packaging of instruments separately is critical. And I think every college, every department should invest in a good sealing machine and have these sealable pouches. The cost for this obviously can be accommodated with the fees or extra sterilization fees or autoclaving fees can be collected by the college for the year for the student. But this is a good practice because the students will know what is the contemporary trends that is being followed in private practice. Many students who are not used to this, they come outside and they don't know how to go about with this. I've seen students with a blank look in conferences and trade shows where they don't know what a sealing machine is. So before we do the sealing, the instruments have to be inspected. So have develop a system where the person who's, after they do the cleaning of the instruments, have to inspect the instrument. The inspection has to be done from 2-3 perspectives. If there is any blood left, or if there is any cement which is dried out, which is not cleaned, or if the instruments are rusted, or something is broken, these have to be identified. So if there is anything left, it fails that test. It acts like a test. If it fails the test, it has to go back to decontamination. Now, after the instruments are being inspected, then they have to dry. They have to dry out the instruments. After drying, you do the inspection. After doing the inspection, then you proceed towards sealing and packaging of these instruments. So use the proper sealing machine. I would recommend a proper sealing machine. If colleges have an issue with that, they can use that sealing machine that you get for the bakery also, that they use to do the bread. That's also, ultimately it just seals. So this is an Indian jugaad way of how we can try to save some cost. But that is also done, but it's a good way of doing it. The sealed instruments will have these color indicator pouches, which will be important. Now the third thing is the autoclaving. A lot of times when the students are doing the autoclaving procedure, we have to instruct them on how to use and how to load a particular autoclave. A lot of times they don't want to autoclave 2 times a day, 3 times a day. So they will take all the instruments, they will take everything and push it into the autoclave. अभी हाथ से fit नहीं होता है तो पैर भी डालेंगे, they will push it inside to make it fit into one cycle. At the end of the day, what happens is useless. The idea is when you're autoclaving it, the steam should come and the steam goes in between the pouches and it rests, goes through. Now you have a plastic side and you have a paper side. Now the steam will not go through the plastic side, it goes through the paper side. It needs to find space to go to the paper side, settle down on the instrument, raise the temperature of the instrument, and then kill any bacteria or viruses which are present on there. If these instruments are kept too much clumped together, then the autoclaving becomes a failure. So make sure they are properly loaded and follow a logbook protocol. I will tell you about the logbook, but coming to different type of autoclaves, there are colleges will usually go with the cheapest form of autoclave that is available, that is the N-class autoclave. But try to invest and upgrade the technology into going with S-class and B-class. It is simple thing. B-class is the way to go because steam will not penetrate when there is air. Now, what a B-class does is it creates a vacuum. It's called pre-vacuum. So it sucks out all the existing air. And then when the steam is purged through, this steam will go inside and will effectively autoclave or sterilize the equipments. So make sure that we invest in a good B-class. If you have a good CSSD, 1 or 2 equipments of this little higher capacity should be sufficient to serve the entire college. Once the instruments are sterilized, there has to be a monitoring mechanism. The monitoring mechanism are usually you have 3 types: physical, chemical, and biological. Colleges should implement. So if you have a CSSD, it becomes easier to implement because in one department you can do. So physical monitoring is what maintain a logbook. Key what time the cycle was set, what all was their description of this instruments, and then if their autoclave gives a printout, then what is the pressure, what is the temperature, what has been reached. That has to be noted down in a book, and one staff in the department is supposed to oversee this and sign it and countersign it. So this is a physical monitoring. Chemical monitoring is now you have these color indicator pouches. These color, whether they are changing or they are not changing, that has to be cut and stapled onto that book along with that signature. So that is a chemical monitoring that could see tomorrow if they are going for NAC accreditation, if you are going for NABH accreditation, these things are important. Tomorrow, today, if we want our college to be reputed, if we want our college to be the chosen destination for a lot more students to come in and apply, I think these are the services that we need to provide. This is the technology that we need to upgrade. Provide chemical monitoring. Provide biologic monitoring. One simple machine, it does not cost more than 5 or 10,000 rupees. Get a biologic monitor. These you get ampules of Bacillus stierothermophilus. Then you put it inside the autoclave. And after the autoclaving cycle is done, you take it out and put it into that machine, which costs about 5,000-10,000 rupees, and let it incubate for 2 days. So if the instrument is, if the autoclave is working properly, all the bacilli inside will die. So the color will not change. If the color changes, it means that the bacteria is still surviving. It means the autoclave is ineffective. So these are ways how we can monitor our sterilization, and then you keep a batch, this batch, and then have a stamp. When every instrument is autoclaved, that has to be stamped and goes back to the department. So that way, if batch number is there, stamp and date is there, if there is any failure, if there is any post-operative infection occurring in a patient, you can trace it back to which day, which batch autoclave was used. And then if there is an autoclaving defect, then that batch of instruments which were used for treating 20 patients, those 20 patients can be recalled to check if there is any infection that is occurring. So this is a responsible way of ensuring sterilization monitoring. This is the format for logbook. I'll be very happy to share it. I can share this entire presentation also, so you can use this presentation to design a template on how you can create a logbook format. Now, lastly, I don't think we have a lot of time, so we will just discuss a little bit about environmental and surface disinfection. This is very important also, because there are non-autoclavable things like your X-ray heads, your computer screens, your non-contact surfaces like your dental chair. How do you disinfect those? Obviously, we have to, before and after every patient, chair disinfection is mandatory. High-level disinfectants can be used for clinical contact area. So we divide the surfaces into two parts. One is a clinical contact surface and one is a non-clinical contact surface. Anything that comes into contact with gloved hands, like your light handle, light switches, aerotor, this tubing, pipes, all these are clinical contact surfaces. These clinical contact surfaces have to be wiped before and after every treatment with a high-level disinfectant. With non-contact surfaces, you can use a moderate, medium grade disinfectant or a low grade disinfectant. What are high grade disinfectants? You can use either extended quaternary ammonium compound, or you can use a sodium hypochlorite, or you can use bacillol, which is, or isopropyl alcohol. These are high level disinfectants that can be used. Whenever we are using sodium hypochlorite, be very careful when it comes into contact with metallic surfaces, it will corrode and it will rust. So hydrogen peroxide can be used in lieu of that. Hypochlorites can be used. Isopropyl alcohols can be used. Certain phenolic compounds can be used as low-level disinfectants for the floor. So you can put like your Savlon or your Dettol or any of these phenolic compounds, even chlorhexidine, that can be used for floor and the low risk surfaces. Now, why I would recommend aspect called as fogging, we're coming to that, is we know that about aerosol and spatter. We as dentists and dental students are going to get exposed to aerosols, and aerosols can carry with them a lot of bacteria. I mean, years ago, about 15-18 years ago, when I was doing my post-graduation, when we were doing a scaling for a patient, I took one agar plate and put agar plate on my shoulder, one agar plate on my thigh, and one agar plate on a table which is 10 feet away from the dental chair. And I did the scaling. After I did the scaling, I took these agar plates and sent it for culture. In that, in the plate that was kept 10 feet away, the amount of bacteria which grew was 1 lakh bacteria grew on that plate, which was kept 10 feet away. So imagine if you are in this and in this, if you are so close, how much amount of bacterial exposure that you are doing. So two things are important. One, obviously, I recommend every student or practitioner to follow pre-procedural mouth rinse with chlorhexidine. That will reduce it by 99%. I have done this study after the mouthwash with chlorhexidine. I redid the scaling, and I found that this disinfectant was very less. So this is from one point to do why pre-procedural mouth rinses are important. And whatever the balance, abhi koi patient hai jisko TB hai, that patient is not going to come and tell you, ki doctor sahab, be very careful, I have TB. So even if a person has TB, they are only going to hide it from you. So the idea is to assume that every patient has got TB, every patient has got HIV or hepatitis B, and take what we call as standard precautions to protect ourselves. To do this, we have something called as a fogging machine. So for the environmental disinfection, I recommend that every clinic has to be fogged every day. So see, WHO recommends there is something called as ACUs, or air change units per hour. So 50 to 60 ACU per hour is what is recommended. Which what it means is, suppose you have a clinic, in your clinic, the air inside your clinic should get changed 50 times in 1 hour. That is, every minute or every couple of minutes, you should get new air into the entire air should be changed. Sometimes we have our windows open, but sometimes the windows are closed. Sometimes AC is on. We never know how much of bacterial contamination or viral contamination occurs because of the aerosol, because they tend to stay in the air for a longer period of time. So for such things, we have something called as a fogging machine. So this fogging machine can be used to fog a particular clinic of 10 feet by 10 feet by 10 feet. That is 10 feet height, 10 feet length and width, and 10 feet height. That is 1000 cc. You can use 15 minutes and that will be sufficient. You can use either a hypochlorite, but because of the corrosive property of hypochlorite, you can use chlorine dioxide, you can use hydrogen peroxide, you can use extended quaternary ammonium compound. These are many readily available, very economical also now. Initially, after COVID, when we started, we used to do after every patient, but now at least once at the end of the day, on a daily basis, we are supposed to do it. But after we do it, make sure all the windows are sealed, and then the whole area, the clinic is closed for about 10-12 hours, so that next morning when you come, it is sterile, right? The other thing that you can also use is, we regularly use cling wraps. Cling wraps are something that, like, food wrap plastics you get there. Used to use food wrap. It's not environmentally friendly, but hey, nothing that we do today is environmentally friendly. The amount of PPs that we are throwing and using and generating is ridiculous. So of course, cling wrap adds to the environmental burden, but we are healthcare practitioners. So at some point we need to take a call. But if your chairside disinfection before and after every treatment, after every patient does not work for you, you can cover up these clinical contact surfaces with cling wrap, and they will protect your equipment also from the sprays and stuff, and you can replace it every so often. So this is regarding environmental and surface disinfection. Session 2 will be, we will talk about occupational safety. So I guess I went about 5-10 minutes overboard, so I'm really sorry for taking a little bit more time. And if there is any questions, comments, concerns, I'd like to take it at this point.
Hello. Sir, the questions, as we are going on YouTube live also, so the questions can be or set on the YouTube chat box as well as these Zoom chat box. And so the moderator for the YouTube is Dr. Amy Thomas, and for Zoom is Dr. Sushant Soni. So what all questions, so they will be posted in the chat box. And sir, as you say, if we should discuss it now or at the time of panel discussion.
We can do, however, I mean, I thought people are tired of seeing my face for 45 minutes, so I thought I'll give a break. If you want me to continue, I'm happy to continue session 2.
Absolutely not. It was pleasure listening to you, sir. So we would, I think, take the question at the end of the session when we get all the questions from Zoom as well as from the YouTube.
Okay.
Yeah, that would be fine, I guess. Anything else, Dean Madam? Would you like to tell anything?
No, it's okay. We will take the questions at the end of the session.
End of the session.
Time.
Okay. Yeah.
Okay.
That would be fine.
Sounds good. So should we start with session 2?
Yes, sir. I think we can go ahead with the session 2.
Okay.
Yeah. We'll. Yeah. You can share your screen. Yeah.
Yeah. Right.
We don't have much questions as such which has come up. So I thought like we can take all these questions together during panel discussion. We will probably have more questions by then.
Yeah. Okay. Students, no, majority, they'll put it on Zoom, they'll put on mute, and they'll be watching flipping channels on TV.
That's true. That's true.
Okay, sir, हम लोग student रहते, when we were students, we also did the same thing. Of course, we did have Zoom. Mentally, we used to block out. So it's very understandable nowadays. In my years of experience, yes, sir.
Yeah, again, it depends on the speaker. If he can hold on the audience, then nothing like that. And I think you were very successful in that.
No, sir, I don't know. Usually when I do talks on practice management. When I do on
Okay.
practice management, I put in there's only so many jokes that you can crack in infection control. In
Correct.
practice management, you can crack a lot of jokes. So
Okay.
there, my sessions are usually more jovial.
Okay.
What happens is when you're face to the live audience, there
Yes.
the interaction is different. In front
Definitely,
of a
definitely.
screen, there is a lot of
Yeah,
difference. Yeah.
I know. That is what I was telling the other day, that this corona has become teachers for all our teachers. Like, it has taught us to speak to a screen and then teach people. So now we have become, we have become very much used to it, like looking at the mobile and then teaching. Really not knowing what is the feedback we are getting from the students. But then yes, we are seeing the results also. We ask them to write the assignment and post it in the classroom.
No,
They are taking up well.
Zoom has become the order of the day. Today,
Yes,
even
yes.
if my wife wants to talk to me, she only arranges Zoom meeting. Because two things. She is very clear because we know who the host is. So
Yes,
that
yes.
is very clear.
Yeah, so she
And the
can always
second
leave it.
important point is the host can mute you.
Yes, yes. That's
So good. Anyway, so coming to welcome all to again the session 2. We thought I'll spare some few minutes for you guys to take a restroom break or whatever. But it's fine.
I think that I think yeah, if you need a break, I think that is justifiable. 5 minutes. I think we can break for 5 minutes. We'll still be in the meeting. If
Yeah,
you want to
yeah, we can still be in the meeting if anybody wants to. Just a couple of minutes.
Yes, yes. I think 5 minutes should be all right. Yeah.
We already gave them about 2 minutes, so I think another 2 minutes and we should be okay.
But I think you also might need to take a break for
No,
a
no,
minute.
no, sir. No, I'm fine. I'm fine. So, I just want to know a little bit about the college. So, how many students do you have? And
I think Madam would be the right person to talk about it. Dean Madam. She's there.
So ma'am is there.
Yeah, I think she has would have taken
Video is.
Oh, sorry. Wrong to expect people when you give them a restroom break and still ask them questions. That's not correct.
that's true. We have 400 graduates. I mean 100 per batch, and then around 22
okay.
same 100 intake and 22 postgraduates in all the departments. Except for Department of Community Dentistry, we have post graduation in all the department.
Okay.
We have almost all the heads over here. They have joined. Dr. Shailendra Sahu is heading Prosto department. He is there, and Dr. Baljit Singh Hora is heading Endo department. Dr. Babita Pawar is heading Perio department. Then Dr. Nagratna PJ is heading Perio department. And
I'm not sure if Dr. Nagratna is the same Dr. Nagratna when she was there in Bangalore.
Yeah. Same madam.
Is she online? Can she come online?
Yeah,
I don't know if she remembers me.
Yeah, madam is here.
I can't see her.
Yeah, I think madam, your mobile is muted. I guess it is muted.
Yeah. Hello, doctor. I'm here. You can see me?
Hi.
Hello.
Yeah. Any connections to Bangalore, madam? Are you from Bangalore?
No, from Mysore.
Oh, from Mysore. Okay. I had one. I mean, you look young. I had a teacher of mine. Her name was Dr. Nagratna. So I thought you are the same.
Actually, there are around 3 Nagratnas in who are pedodontists. So Bangalore also, I think there are 2.
Yeah.
I'm from Mysore.
Nagratna, I know. How are you, madam?
Yeah, I'm good.
Good.
I think we can continue with the session. I think all are back.
Yeah, all are back. Okay.
Yeah.
Session 2, we want to discuss a little bit about occupational safety, and I think it's really critical. A lot of us protect ourselves against infections, and this part is mainly focused on the staff protection, things that we can do to protect ourselves from getting infected. So obviously, you're wearing a gloves, you're wearing mask, you're doing all this stuff, but some things that we are inadvertently exposed to, and how do you scale down that risk? So first thing we want to talk about is immunization and bloodborne pathogens. We all know that we as dentists are exposed to pathogens day in and day out, either through blood or through aerosols, even respiratory pathogens. So as far as blood pathogens is concerned, the risk, what is a high risk, what is moderate risk and low risk, depends upon the infectious agent that we are dealing with and the secretion. So if you look at saliva as a secretion in the oral cavity that's faced with saliva, and to a certain extent GCF, poses a moderate risk. But these things stand to change now because of the COVID, because roughly, if you look at HIV, the amount of copies of RNA that you find in saliva per ml is about 140 to 150 copies of RNA per ml of saliva you see. But when you look at coronavirus, you can see roughly 1.2 million copies of COVID and NCOV2 in the saliva. So obviously we are at a much greater risk, and that's why corona has played such a significant role as far as dentistry is concerned. But surprisingly, the amount of dentists who are suffered from corona is, as a percentage of the population, is very low. Thanks a lot to the prompt steps taken by the associations, by the councils, by the advisories issued by the government, and dentists themselves, who a majority of them are in the aging population of dentists. So the self-care that has been taken by them has gone to a large extent in protecting or reducing the number of infection among dentists. Having said that, just want to ask all of you, if you all guys know how prevalent is hepatitis B in India. Just at what percentage of people do you think may be positive for hepatitis B? Just in your view, if anybody could just say. Well,
I think there have been quite a few cases which has been reported that dentists have died because of hepatitis. I don't know the exact percentage, but that I have read about the reported cases.
Well, in a dental college, I don't want to name, I randomly went to that dental college and did a study. I did a blood test of all the staff members, 76 staff members, and found out how many of them are positive for hepatitis B. 36 of them were positive for hepatitis B. Surface antigen, HBS. And this is despite all the vaccinations and despite all that. So the prevalence of hepatitis B is phenomenal. Now, if you just look to your right and your left, one among the three of you will be positive. So 1/3 of the dentist population today will eventually turn out to be positive for hepatitis B. That's the kind of risk there are. And we're talking about COVID, and we're talking about how it is for a disease that disappears in 2 weeks. Hepatitis will never leave your system for 20 years also. So the risk that is being for dentists is 1,000 times greater risk from hepatitis B than COVID. And for such a small amount of risk in the general population, such a ruckus and hue and cry is created in the country. To what extent the economy is getting affected? But what about the dentist? The dentist has been exposed to far more greater, far more severe, and far more commonly encountered pathogens. Now, I have very close friend. She's a batchmate of mine. She had hepatitis B, and it's been 20 years since she's gone to a restaurant, gone to a public place, watched a movie, had a glass of wine. It's difficult to live your life like that. Trust me, when you have it, it's very difficult. So we at dentists are at great risk for some of these pathogens. So college should have a strong immunization policy, a strong immunization policy. All the students, all the staff members, all the non-teaching staff, everybody should be immunized for hepatitis B. Before doing the immunization, antigen testing has to be performed for all of them. Do not, I mean, that spot test and all that they do, I don't know how reliable it is. Do 2 times. If it is positive, repeat it the second time. The people who are positive for hepatitis B surface antigen are not candidates for vaccination. So before doing the vaccination, don't give vaccination to people who already have hepatitis B in them. It's dangerous. So first thing we have to do is, before planning the immunization policy, we have to perform antigen testing for all prior to vaccination. For people who are positive, they are not the candidates for vaccination. For people who are negative, you plan the vaccination. The vaccination has to be given in the 0, 1 and 6 months. Many times I have seen people who have vaccinated have a comfort that I am now vaccinated for hepatitis B, nothing is going to happen to me. Now, whether the vaccination is successful or not successful depends on how many antibodies your body is producing. So, just giving the vaccination is not sufficient. 6 weeks after the vaccination is done, antibody testing has to be done. Antibody, specifically IgG, not IgM. IgM is non-specific response. IgG, antibody specific to hepatitis B, has to be tested. Only those people who show a positive antibody response are considered protected against hepatitis B. Those people who, despite taking the vaccination, are not showing the antibodies are what we call as non-responders. So we don't even know today how many are responders, how many are non-responders. So after we do the vaccination, we wait 6 weeks, then check the antibody response. If a person is a non-responder, the protocol is a second vaccination again of 0, 1 and 6 has to be given for second time. Sometimes some people are like me, you know, they are a little slow. So you have to push them second time. The immune system the second time has to be pushed to get the response. So we check the second time and then take a decision. A person who, despite after the second time, does not show an antibody response should be counseled, saying that they are at permanent risk for hepatitis B, and so they need to be a little careful, right? Even if you are positive for antibodies, that means even if you are protected against hepatitis B, it does not mean that you cannot get any other pathogens. There are hundreds of other pathogens also that you can get. So the standard precautions has to be followed by everybody to protect ourselves from any sort of injury that we occur during the dental treatments. When we are doing the aerotar, when we are giving LA to the patient, sudden movements by the patient, we can get ourselves pricked, right? So these things. Now, this is just for the staff and for the students. What should be the protocol followed by the college? Now, there are 2 types of antigens. There is a surface antigen and there is the envelope antigen. Now, when a person is positive for surface antigen, if it is confirmed, then we have to check for envelope antigen. Now, what it means is, when the surface antigen is positive, but envelope antigen is negative, it means that the person is only a carrier. That means the virus is not infective. The patient is only the doctor is only a carrier. But if the envelope antigen is also positive, that person is infective state. That means they can infect others, and at the same time they are at risk for renal failure or liver failure. So in such people should take proper antiviral treatment. So when the surface antigen and the envelope antigen both are positive, the doctor or the student at that point is considered to be infective. And such staff, such students should not be allowed to perform clinical duties till such a time as the envelope antigen becomes negative. Usually it takes about 2 to 3 months of antiviral therapy till the envelope antigen goes back to negative. This has to be reconfirmed by ELISA alone, ELISA test alone. So ELISA has to be done, and then as a confirmation, if it is negative, then they can be allowed to resume their clinical duties. This should be the policy as far as the immunization is concerned for hospitals and clinics. In order to protect them, every college must have a sharp injury protection program. Now, to protect them, every sharp injury that occurs, whether it is a student, whether it is a faculty, or whether it is a non-teaching staff, whenever they are washing the instruments while wiping down everything, to protect this, at the first step, you must develop some controls. These controls are engineering controls. It could be work practice controls. These controls are important to protect the staff and the students from getting themselves infected. So every student, after they perform the procedure, every clinician has to wipe down their instruments. They have to wipe the instruments on the chair before degloving themselves. Then when the instruments they are carrying it, they should not carry it in their hand. They should carry it in the tray. These things will protect against sharp injuries. Once in the tub, they wear the heavy duty utility gloves. These are again controls that will prevent them from from getting infected. Once, if they get infected, there is what should be post-exposure management. What they should do: keep their fingers under running water. Don't try to squeeze it. Don't try to squeeze the blood, because negative suction can create suck the blood inside. So without any pressure, they only have to wash their hands under running water for about 30 seconds. Then wash them with simple soap and water. Then go for a blood investigation of 24 hours, 48 hours, 96 hours. After every 24 hours, they have to keep redoing their test for hepatitis to check if they are exposed. Once a sharp injury occurs, there has to be a form that is filled. It's called incident filing report. An incident filing report should be maintained where in a template is created. That template should have the name of the person, how they got, a description of the event, how that injury happened, and that has to be submitted to a particular office. Then that office should review that, should meet it, identify where the problem has occurred, whether the problem is because of the staff not being trained properly, the student not being trained properly, or whether the process, something is wrong that needs to be changed, so that in future similar kind of injury should not occur. So there has to be a second report that has to be filed called as action taken report. This action taken report will ensure that, one, there is documentation of the incident. Two is what steps the organization has taken to prevent any such injuries from occurring further. And to monitor this, the sharp injuries occurring in the college every year should be published, saying that last year we had 35 sharp injuries. After incorporating the sharp injury prevention program, it has come down to 12, or it has come down to 10. Second year it has come to 3. Third year it has become 0. Ultimately, the objective is sharp injuries should be 0 in the college. The problem is, many times the staff, the non-teaching staff, they may get pricked, but they don't even report it. If you ask, I can challenge you, you call all the non-teaching staff in your departments, you ask them one question: have you ever got pricked while you're washing the instrument? There will not be a single person who says, no sir, I have not been pricked. Either they're lying, or definitely they will say, yes sir, adella yen sir aagte rehte hai. I mean, it keeps happening, usme kaun si badi baat hai, ye to hota rehta hai. This is the usual response. Most of these people are uneducated. They don't even know what risk is there. So as our staff, as educated, our responsibility to ensure that we conduct proper training programs for the non-teaching staff to make sure that they are aware of all these policies, they are aware of all these practices, they protect themselves and their families from such injuries that can occur. Second and last part we wanted to discuss today is the biomedical waste. Now, a biomedical waste is any waste that is generated during the diagnosis, treatment of anything. The definition is clearly written in front of you. Now, biomedical waste today is become a very significant matter. It become very significant matter because years and years of neglect have caused a lot of diseases to spread in India because of lack of training, lack of awareness, lack of programs that are aimed to make the public aware that such diseases can spread from the hospitals to the community. Many times hospital waste is just mixed along with the regular waste. Many times the dental chair water line that comes is just disposed into the community water. These are crimes, actually. These are crimes. And the government today is taking it very seriously. There are various protocols in place. And if any doctor in their private practice or in the hospitals is found violating the biomedical waste, because I was giving this webinar, I went on the website and I checked Chhattisgarh. What is the government of Chhattisgarh's responsibility towards biomedical waste? They have so many cases pending. The cases have been filed against private practitioners, against hospitals and nursing homes for violating the biomedical waste. How much of waste is being generated by the hospitals, how they are segregating and how they are disposing the waste is becoming a big matter of concern. So this point is extremely important. Of course, if you look at the risk, according to WHO, they say 85% of the hospital waste are actually non-hazardous. They are non-hazardous. 10% of the waste are both infective and they are hazardous. But 5% of the waste are non-infective, but they are hazardous. What do you mean by non-infective but hazardous? Example, mercury. Mercury is not infective, but it's hazardous. So like that, some wastes are both infective and hazardous. There are some wastes which are non-infective but hazardous, and there are non-hazardous wastes. The disposal of this biomedical waste is done mainly to minimize the spread of disease. Now, spread of disease can occur because, as I said, there is a chain of infection. As long as there is a port of entry and port of exit and a susceptible host, infection can spread. So proper disposal and segregation is important to minimize the spread of disease, to reduce the overall infectious matter. Overall infectious matter that is produced, I mean, dental clinics are very less, but medical hospitals also produce a lot of infectious matter. And to prevent the environmental pollution that occurs as a result of this. Second-hand market of needles and syringes is such a big industry in India. Today, even till 10 years ago, there was such a big scam about hospitals just throwing their syringes, and there are rag pickers, there are rag beggars and rag pickers who collect these used syringes and they sell it. And there is a market where they buy these kind of syringes, and some of the same pharma companies buy these ones, sterilize them or wash them, repack it, and they could be resold in the drug market or second market or I don't know what. So these kind of issues made the government aware that there needs to be stricter laws that need to be implemented to prevent this spread of such kind of infections and disease. And so there are certain policies that need to be implemented. What are these? The first is segregation at source. Segregation at source means even our homes now, you have dry waste and you have wet waste. Similarly, biomedical waste, you have to segregate at the source itself. Only when you segregate it, it is possible to properly dispose it. There has to be a dedicated space for storing the biomedical waste. In every college, in a dental college, there has to be. So in a few of the dental colleges where I consulted, I have asked them to build a separate room, a separate concrete structure for disposal, for storage of this segregated waste. Sometimes many colleges I have seen where the bags are just tied and thrown in one side. Next day when you come, there are dogs which chew open the plastic bags, and all the contents of the waste, including the gauze and the cotton and the plaster and the casts, are all strewn across the place. So storage is a critical area where the colleges need to implement a dedicated storage space. Transport. Now, either there are some colleges that can transport their biomedical waste to the agency or to the place, or depending upon the waste generated, they will send a hopper truck where they collect and they collect and go and they dispose it. So this is the process for biomedical waste disposal. As far as inside the departments are concerned, some of my recommendations include, I have seen many colleges where next to every chair there is one dustbin that is kept. So in that dustbin, everything, right from gauze and cotton to gloves and paper and all waste is just put in one bin next to the chair. Please remove all the bins from every chair. So every department should have only one. Maybe if you have a UG section and a PG section, you have one set of bins for the UG section and one set of bins for the PG section. One set of bins for every department. One, get a bigger sized one, maybe a 300 liter, 250 to 300 liter should be sufficient for one department. So label each bin, whether it is a plastic waste, paper-based waste, infectious waste, any other sharps container. These things have to be labeled and color-coded. Also, in India, it is if you tell somebody, it will not happen. You have to show them. So take a picture. So suppose in a black bag, you can put mask, you can put patient drape, you can put paper-based waste. Take a photo of the mask, take a photo of the patient drape, take a photo, put it in one laminated sheet, stick it onto the bin, saying that these things go inside. Then if you have a yellow bag, gauze, cotton, extracted teeth, whatever is there, that goes into the yellow bag. Then red bag, you put your gloves, you put your syringes, you put your casts, POP or whatever that alginate impressions, that goes into one red bag. So label them, put photographs and stick onto the bin or onto the wall where next to the bin, and follow that. Segregation is the responsibility of the staff or the student who is doing it. You cannot expect the non-teaching staff to dispose the waste that is being generated. Every student, when they finishes treating, or today the students, when you are become practitioners, before you remove your gloves, it's your responsibility to take out the waste and then throw it into the respective bin, right? Don't just like a cardiac surgeon, just get up, mera treatment ho gaya, remove the gloves and expect somebody, your mother or someone, to come behind and clean up after you, right? Take up the responsibility. Segregation is the responsibility of the person who's treating, could be the staff or could be the student. So these are some of the bag color coded ones, which is routine. These keep changing. Unfortunately, in India, state to state variations in color keep happening. Within the same state, after a couple of years, they will change the color of different ones. So what is the latest one I could find? I have kept here. You keep a black bag, yellow bag, red bag, blue bag, and a sharps container. So basically paper-based waste, including your masks, your disposable cups, patient drapes, all that can be put into the black bag. Then you have a yellow bag, which is basically an infectious waste, which contains all your blood-soaked items like your gauze, cotton, and anything else that is blood-soaked. Then other thing is your red bag, which is infectious. That is also infectious waste, which contains all your casts, what you use, plaster, especially when what happens today, impression, we don't disinfect, no. You take the impression from a patient, you wash the impression under running water, and you directly pour the stone, or you directly pour the POP over it. So what happens there is whatever bacteria and viruses are left on the impression gets transmitted to the cast. So the cast also becomes becomes infected. So that also becomes an infectious waste. So that needs to be put into the red bag. There's cast, plaster, alginate impressions, all these putty impressions and stuff like that. Then there is a blue bag. The blue bag is for all your plastics, whether it's your syringes, your gloves, and any other plastics that you use, you put it into the blue bag. So you need to have 4 different bins. And then there is a separate container, which is called as a sharps container. Now, sharps container is in many colleges, either they buy the sharps container, or sometimes you get these acrylic, what you buy, this powder for denture powder, what we buy, that 5 kg bin, we can open that. That's puncture proof. The idea is it has to be puncture proof. When someone lifts it, the syringes or anything, blades or anything that is put inside should not prick the hand of the person who's handling these wastes. So a dedicated sharps container need to be placed, which is basically puncture proof. And one of the main instructions for a sharp container is always immerse it with hypochlorite. Put it inside so that it remains disinfected. It will get rusted, not a problem. But after some time, you keep disposing it. The container of the sharp should not exceed more than 3/4. So sometimes the sharps may spill over and injure the hand. So the mark a line at the 3/4 level, and once the waste crosses that level, no further waste should be put on it unless it is disposed. So these are the guidelines. As far as, of course, you have sometimes extracted teeth which also go into the yellow bag. Now only thing you can put this into the yellow bag. One thing is, if there is any mercury which is fillings or anything is there, that filling need to be removed, because all these wastes are basically incinerated, they are burnt, right? So when they are burned, if you put mercury and burn it, there will be some vapors which are released into the environment, which is not very good. So mercury and all has to be removed. There is a separate solution for that mercury where you dip it into that, and there are agencies, the same agencies can come and collect the mercury and they will take it. They will actually pay you for it. Even that, your your fixer solution and your developer solution is okay. Developer solution can be drained into the sink, but the fixer solution cannot be drained into the sink. There is an agency that comes and takes it along with that lead foil. Inside the X-ray films, that lead foil can be collected. People pay you money for it, and fixer solution also people pay money because they extract some silver or something from that, or something they extract, so they pay you also for it. So that can be also disposed of in a safe manner. Now towards the end, I just want I have certain guidelines which I think will be helpful for colleges to establish a proper program called infection control monitoring. It is extremely important that every college has an infection control office. I usually call it as OSIC, or Office of Safety and Infection Control. Institute a separate office, have one dedicated person who's going to head the infection control program. Then have departmental representatives. Every department should have one representative for an infection control. So that team has to meet every month to discuss the problems and to discuss effective methods of educating, training. So the fundamental responsibility of this group is to, one, ensure that there is no patient cross-contamination that occurs in the hospital. In your private clinics also, you take up the responsibility of doing that. But as far as colleges are concerned, have a policy, have an infection control manual. I can always help you with that. I can send it across to you, you can use it. The infection control manual will be a Bible for every person working. All the students, when they enter their 3rd year, we have a ceremony called as white coat ceremony. That is, we give them the white coats so that they can enter the clinics and start working on patients. Before they enter the clinics, I have a 2-day, full-day program on infection control, and I conduct exams towards the end, at the end of which only then they are allowed to enter the clinics to do the work. So from infection control perspective, we can give them this infection control manual that they need to go through, understand the risks associated with it, follow the guidelines, follow the protocols, develop standard operating procedures that are responsible for it. The idea of any program should be always there should be a policy, Now, create and define a policy. Second, there should be objectives. What the policy determines, what the objective of the program is. Third is you have to have dissemination of information. Whatever you want the people to follow, you have to conduct extensive training programs to all the staff, to the students, to the non-teaching staff, everybody included, on what are all the guidelines, protocols, and rules that you expect them to follow. That is point number 3. Point number 4 is, if there are any infrastructural changes that need to be made to ensure the proper implementation of the infection control program, it's the responsibility of the college to do it. That is point number 4. And last point is, you have to monitor. Whenever you're having a program, if you want the program to be successful, you have to monitor it. Now, how do you monitor it? You give every department a score, right? What I do is, I say that oral medicine staff representative of oral medicine will inspect oral surgery. Oral surgery will inspect perio. Perio will inspect conservative dentistry. Conservative dentistry will inspect orthodontics. Orthodontics will inspect public health. Public health inspects oral pathology. Oral pathology, like that you can, and some two staff may not get along and they'll put bad report, or I don't know. You can keep shuffling. You can keep shuffling the staff to prevent any personal biases that you can see. Otherwise, too much of enmity also is not good. Too much of friendship also is not good. They will say, "Arey, maadkonbida, tu kar le yaar, dost hai mera, tu dal de 000 sab mein." So, one head of the infection control program has to oversee all this. The point is, when you have a monitoring form, it should the template should have some violations. What are the violations? You divide the violations into minor violations, major violations, and critical violations. Now, minor violations matlab kya? Some say dust is there where the sister should have cleaned it, but cleaning nahi hua hai, thoda dirt hai wahan pe, the windows are not clean. So that comes a minor violation. Somebody somewhere, someone is not wearing the scrub properly, or that scrub is stinking. When you implement the scrubs, that scrub also has to be washed. That personal hygiene should be there. People are wearing the same scrub for 3 days, 4 days, and they start smelling. So personally, when I used to go close by and smell. Kya karna hai? We have to do it. So people have to, these kind of violations. Then there are major violations. Then there are critical violations. Critical violations could be using unsterile equipment, instruments on patient. That's a critical violation. You cannot, intentional fraud that you're doing to hide, that is a critical violation. So these are certain, you have to design what you consider as critical violations, and whichever department has got a critical violation, the head of department is answerable for that. Somebody has to take responsibility. Somebody is answerable for that to a platform. So and then obviously there is when there is a stick, there should also be a carrot. So carrot and stick should be their approach. Reward the departments which are doing very well, and punish the departments which are not doing well. So punish or motivate or whatever, however way you would like to do it. But this is the only way that infection control will succeed. If we do not show that kind of enthusiasm, that passion, that commitment, and the drive to make this program a success, this will not happen. And this does not, if 9 out of 10 people in the program are committed, it will still fail. So if you want this program to succeed, you must have each and every person on board. Only then this program will be successful. So this is a sort of an infection control monitoring setup. Just a few guidelines because of COVID, because of the COVID situation, how to handle colleges, how to handle patients during this COVID time. Want to spend 1 or 2 minutes just on giving a requirement on this is ensuring safety of patients, safety of faculty, students, and setting up of a teleconsultation desk and a helpline. See, as the days are progressing, we are becoming more and more lax as far as COVID is concerned. Things are getting back to normal, but there are certain guidelines which I think good points of this of this pandemic that has taught us. We should make it as a permanent practice. Having a teleconsultation desk is very, very good. Giving out the number of our hospital to the patients before they visit will encourage us in taking a brief questionnaire. And during this COVID time, I don't know if all the departments are functional. I recommended a few colleges to not open all the departments, but have only 3 or 4 departments, and which is actually good for dentistry. I mean, this takes a different perspective when education system needs to be improved. Fractionated care, the patient has to go to room number 1, then 2, then 3, then 4, then 5. Instead of that, have clinics, remove the names of the departments and have clinic A, clinic B, clinic C, clinic D. And then clinic A, have one oral surgery staff, have one perio staff, have one prosto staff, have one endo staff, and a pedo staff, all of them in each department. In each of the clinics should have a representative of all the departments. Any patient who comes there, give that one chair to that particular student. And that student does all the treatments like a comprehensive care for that. If there does a endo work, the endo staff will check. If it does a perio work, the perio staff will check. If there needs an extraction, the oral surgery staff will check. So that way you are minimizing the number of open departments, the number of areas where you need to monitor and do the infection control properly. And at the same time, give the student a more holistic way of treating a patient in terms of how they would once they graduate from the dental college and start their own practice. Doing comprehensive care in one chair, in one setup. Give that chair to that particular student so make that the responsibility of that student to take care of the chair. So they get that consciousness and responsibility of managing the equipment also. The chair, it's their responsibility that they make sure that the chair is clean, that chair is taken, and then you can inspect it. Have an emergency care and elective care. So separate department for emergencies or a separate area where emergency dental treatments are being done. One thing which is important, especially when we have hospitals and colleges with a large number of OP, is the entry point and the exit point. If it is feasible, have to have a back door to the college or a backside entrance or a side entrance or any other entrance. Use that one way for entry of the patients and one other thing for the exit. And the floor can be marked in arrows. So we always recommend that for the patients in the local language, it is written in the local language, and paste this colored arrow with on the floor. So with instructions, please follow the line to clinic A to clinic B. This is entry. Then for exit, there is another arrow that is pointed and patients can go out in that same area. So that while interacting, while crossing each other, the number of the crowd in the area can be controlled by having separate entry and exit points. Create a triage center where only patients can enter. Do not allow the attendants or everybody to come inside. And then you have a help desk which helps for screening of the patients, and then have a check on the vitals. Pulse oximeter, I would recommend. Most of the people do this non-contact thermometer, which is frankly of no use because most of them don't even work properly. The other thing that you can do is silent hypoxia is going to be a big killer. So pulse oximeter for every patient, I think to check is very important for asymptomatic COVID patients. And obviously you have some Arogya Setu app that you can check to see their exposure status and the risk status. You can restrict the times in the colleges, and for the staff can work in shifts to reduce the risk. All right. Then obviously we have a COVID specific consent form which has been issued by the dental associations. We can use that as a standard thing for every patient that walks in. So this is just how we have done in our college. What we have done, we have created separate areas, certain clinics. This is readily available in our website. You can go through this. I mean, I'm not saying this is the only way to do it, but this is how we have done it. A lot of colleges can do this. Yeah, so just salient points is entry and exit of the patients can be made separate, and staff student entry in the clinic should be preceded by hand hygiene. Have a central sterilization unit, try to create a CSSD platform, a separate area for donning and doffing of the PPEs, and chair disinfections and environmental disinfections. Please make it mandatory. I don't know if each department has their own fogging machine, or buy a few fogging machines and create a timetable and then run it. But every department to be fogged on a daily basis is important. You can use sodium hypochlorite, or you can use accelerated hydrogen peroxide that's available, or you can use extended quaternary ammonium compounds. All these are effective. The only thing with the quaternary ammonium compound is extremely effective, but the contact time is a little longer, so you need to expose it for at least 10 to 15 minutes. Whereas with the hydrogen peroxide, even a couple of minutes is sufficient. So yeah, and thank you. And just want to thank at the end the entire team of Chhattisgarh Dental College for giving me this opportunity. The board of directors, Parak Saab, Shri Modinji, Golcha ji, the dean madam, Hema Suryavanshi madam, a dear friend Dr. Pramod Krishna sir for giving me this opportunity. The entire organizing committee, the student organizing committee. Thanks to one and all for a patient hearing. I know I've spoken a lot, but at least you had the privilege of muting me. So thank you once for this opportunity.
Thank you, sir, for your brilliant and discerning ideas.
Thank you.
Sir, we would like to provide you with a token of appreciation.
Okay.
Thank you, sir, for crystallizing us with this topic.
Thank you. Thank you.
Learn from yesterday, live for today, hope for tomorrow. The important thing is not to stop questioning. So now we have our panelists, Dr. Shailendra Sahu, Dr. Babita Pawar, Dr. Abhijit Diogare as our panelists, and the moderator, Dr. Pramod Krishna. Over to you, sir.
Yeah, thank you, Palak. Hope I'm audible.
Yeah, yes, sir.
Yes, sir.
Yeah.
Yes, sir.
At the outset, I would like to congratulate Dr. Krishnaraj Ganesh Narayan for a very extensive but what to say, gripping lecture. I mean, we all were very. You never let anybody get bored for even a second, I guess. And coming on to the aspects of what you had said, yes, related to the waste management, yes, what you said, I totally agree with you that we need not have to have dustbins in, next to every chairs. And yeah, we do practice the same over here. We take the all the disposed item in a kidney tray, go directly to the place where it is, where the waste disposal bins are there, and then dispose it. And also we ask the students, and even we ourselves, wash our hands before we remove the gloves also. So that is one thing which we are teaching our students to do, that to wash our hands and then remove the gloves, so that even the mildest blood or whatever is there is washed off. Then coming on to our panel discussion, I think sir had told that the impressions are very rarely disinfected. Yes, yeah, that is the most common thing which we see. But then there is a procedure of disinfection of impression. I think this question can be taken up by Sahu sir. Sahu sir, can you hear me?
Yes, sir. Yes, sir.
Yeah. I think this question can be taken up by you, that disinfection of an impression, like what exactly would you prefer to do? Like how it is exactly done?
Disinfection of impression, there are basically two methods, immersion method and spray method. Now, from microbiological point of view, immersion method is preferable. But problem with the immersion method is you lose some dimensional accuracy, which is very important for the impression. So most of the time we prefer spray method. For alginate and agar hydrocolloid impression material, spray method is the method which you can follow. But when you are using the spray method, you can use solution like hypochlorite 1%, spray it and cover it in a bag or a box for at least 10 minutes. So that covering is also important so that microorganisms are not sprayed in the clinics. For elastomeric impression material, some material are hydrophobic and they can be immersed. For immersion method, you can use again hypochlorite or 2% glutaraldehyde. Now these impression materials, because they are ultimately poured in the spoon, so now these impression materials, they are mostly converted into the hydrophilic. So silicon impression material nowadays, what we are getting, they are also hydrophilic. So again, you have to follow the spray method.
Okay, sir. Is there any role of digital impression to overcome this problem of disinfection? Like, what exactly is digital impression?
Okay, yes. Now, digital impressions, their scanners are available. So, intraoral scanners are also available. There, you don't exactly require the impression. You totally eliminate the step of impression. But only thing is, you will have to invest on the scanners. And scanners are quite useful for the fixed partial denture cases. Now, there are studies which say that it can be used for the complete denture cases also, but they are most preferable for the fixed partial denture cases. This will completely eliminate the making of impression only.
Yeah, I think this will be a cutting edge technology which would probably obviate the need for making an impression. Can impressions be autoclaved, sir? I mean, is it autoclavable?
Now, yes, few companies have come up with autoclavable impression materials, basically the silicons. We are lacking in the number of studies. Some studies that there is no effect on dimensional stability. Some studies coming up with contradictory results. We have to wait before we can actually go for the autoclavable impression material. But yes, they are available in the market, autoclavable silicon impression materials.
Okay.
But one thing is, whenever you are using impressions, before going for any disinfection, completely wash the impression. So that will remove a lot of biofilm and all those things and make the disinfection easier and more.
Any of the any other point of view to be shared by any other panelist? Okay, sir, I have some more question for you, Sahu sir. One is the disinfection of prosthodontic instrument like articulator, and like these are all probably semi-critical instruments. So what is your recommendations?
As Dr. Krishnaraj has explained, these instruments can be divided into 3 categories. Now, articulators comes under non-critical. So, but again, one thing we should take care is articulators, we should not take it to the clinical area as far as possible. If you are taking the articulators to the clinical area, that means they are going to be, there are more chances of getting it infected. So if possible, take only the prosthesis to the clinical area and keep the articulator away. But phase bow come under semi-critical area, semi-critical instruments. They are made up of metals, so they can be autoclaved. And if possible, they can be directly run over the flame before using it on the patients. Now for articulators, you can use soap water for washing it. And again, they are quite expensive instruments. Should be very careful while applying any chemical over the articulators. So refer the manual and follow their guidelines. So preferably strong acids, alkalis should be avoided on those surfaces.
Okay, sir. I have one question which has been lingering in my mind right from my undergraduate time. That like when we make a impression for a complete denture, we lose the manual dexterity of making the impression if we wear the gloves. That is what some old timers used to say. Like, what is your point of view on this?
No, we should always use gloves.
Okay.
Even if we are making a impression, if we are using impression compound also, then I mean, there is no option. You have to use gloves. Without gloves, don't use. And now this putty impressions, they have some problem with the powdered gloves. So there you can use nitrile gloves, but always use gloves.
Okay. And your take on disinfection of wax bites, trial denture, and prosthesis?
Same agents can be used. Only problem with this wax bite is when you transfer it to the cast, your cast will also get infected. So again, as far as possible, when you are removing the wax bite and in between the patients, then don't transfer it to the cast as far as possible. And again, if you are transferring the wax bite to the lab, it has to be transferred after disinfection. Same agents can be used for that. And for if dentures, or if you're trimming the denture base, temporary denture base, then you have to take care of the disinfection of the burrs, micromotors. That thing also have to. Burrs can be autoclaved.
And occupational safety measures pertaining to infection control in laboratories?
Yes. Dr. Krishnadas sir has very fine explained the occupational hazards for the personals also. So for in Prostho lab, one thing you make sure that anything which enters the lab is disinfected. That is the best way of preventing the spread of infection in the Prostho lab. So whether it's impression or some processes which is going for the repair work in the lab, has to be first disinfected, then transferred to the lab. And all the protocols which has been very nicely explained, that has to be followed in the lab also. So they must be educated.
And sir, what is anti-retraction handpiece, its role in disinfection?
Handpieces, particularly air rotor handpieces, what happens, they work on the air pressure. So whenever we stop the handpieces, it sucks some air, and this air can enter the pipelines. So even if you are using the autoclave, the handpieces, if you are in the next page, that suck air can again go into the next patient. So that's why anti-retraction handpieces they have come, that doesn't suck the air from the patient's mouth. But again, it requires some sort of investment in the handpieces and the entire equipment, entire pipeline.
Thank you, sir. Thank you very much. Krishnaraj, sir, do you have anything to add for what we have discussed now?
Sir, no, I think sir has explained everything wonderfully. I think what he mentioned, both the immersion technique and the spray technique is what is really valid. Excellent valid points. He said one more important point, do not bring equipments or materials which are not required into the clinical area. So that is a very, very important point. And finally, about this anti-retraction, yes, anti-retraction handpieces, they as time progresses and it becomes more affordable, I think definitely that should be encouraged. That should be encouraged for sure.
Over to Babita madam. I think you both are of same specialty, so I think most of the things he should have already told. Anything else you would like to add to what has been told, madam?
No, sir has explained everything in detail. Yeah, like while doing now, most of the Ministry of Health and Family Welfare, they have not recommended use of lasers or you say ultrasonic scalers.
Actually, I wanted to ask about the same.
Yeah.
Actually, role of.
So, but then when we have to use it, now we are coming back to normalcy, right? But then we have to take due precautions. We can't be scared, So now now these viruses are lipid enveloped, right? And those our oral cavity is full of AC receptors. AC angiotensin converting receptors are maximum in our oral cavity. That's why there are maximum load of viruses like on the tongue, on the these cheeks, and in salivary glands, right? So we have to do procedural rinsing with mouthwashes. There are various studies they have shown that this pre-procedural rinsing and even between the procedure rinsing with hydrogen peroxide or povidone iodine, because these viruses are very you can say vulnerable to oxidative mouthwashes. So pre-procedural and in between procedures, then use of high vacuum suctions, four-handed dentistry, then use of high vacuum evaluation to be used that should be kept in close contact with the ultrasonic unit within 2 centimeter of that ultrasonic scaler can be used. Then, as Sir said about PP with the hood, double layer of PP, then HEPA filters is quite expensive, but if you can use, you can go up for it. Then fogging, as Sir has nicely explained, with 20% hydrogen peroxide. Yeah, so then the same protocols like exhaust fan, proper ventilation, then the fan should be kept behind the operator. Unidirectional flow of air. If you have to work under air condition, then it has to be serviced properly. Filter has to be serviced properly. So all these precautions to be taken.
Okay, madam, that sums up very well the gist of today's presentation.
Thank you, sir.
Over to Abhijit, sir. I think oral medicine and radiology is one specialty where radiographs keeping an intraoral films. Dr. Abhijit is there?
Yeah, I am here.
Yeah. I think what I would like to know from you is what care should be taken while using a digital intraoral sensors, like as far as in.
Because nowadays what we are practicing. We have IOPS machine in the department, and we are taking IOPS, which is actually not recommended in this COVID times. That to reduce the number of IOPS, where we shouldn't take. Instead of that, we can go in for extraoral radiology, like OPG or CBCT for the patient. And if there is a need of using digital sensors intraorally, basically we can use long plastic slips. The sensor should not be used directly into the patient's oral cavity. It shouldn't come in contact with the saliva, and they can be discarded every time. And what I prefer would just say that because for every patient you should use separate pair of gloves, so that those contaminated gloves, they do not come in contact with the X-ray machine every time. So the protocol says that the X-ray machine should be covered by plastic. So, and that should be changed, but that's very difficult practically in a setup like that. So at least we can change the gloves and we can use it so that the transmission of infection can be reduced.
Thank you very much, Abhijit sir. Because we have lack of time, I have quite some questions which has come up from the audience. So we directly get into that. There is one question which I think everybody knows the answer. That is, can an N95 mask protect us against viruses like COVID-19, or only bacterial infection can be prevented? I think I would like this question to be answered by Krishna Raj sir.
Hello. Yeah.
Yeah.
So the question was whether N95 mask is effective against COVID.
Yeah, viruses like COVID-19 or only for bacterial infection. So what they meant probably is whether it is only effective against bacteria or it is effective against viruses also.
Yeah. See, the pore size is what is very critical in a mask. See, the size of the virus and the size of the mask, the porosity of the mask will determine whether the virus can get inside or they cannot get inside. N95 masks, if you look at it, there are multiple layers inside it. So although the porosity of the mask of the N95 mask is greater than the size of the virus, the presence of multiple layers will act as an effective barrier. Number two is the N95 mask has got a hydrophobic coating also. So that also kind of helps in protection against the entry of the COVID. N95 mask for sure will protect. Of course, nothing is 100%. That is why it is N95. That's why it is N95. 5% वो लोग भी अपना लेते हैं ना कि कल कुछ हो गया तो केस डाल देंगे उनके ऊपर.
Right. And the next question is how to next question is from the same participant who's asking how to disinfect instrument in between patients, like if we want to do 5 patients back to back. I think it is very obvious we have to have a 5 different set of instruments.
Exactly.
Or it has to be autoclaved
yes,
after every case.
Yes.
So that's the thing. Then one person is asking, please let us know some commercial brands to be used in fumigation.
I don't know if I should
conflict
mention.
of interest.
Yeah, I'm not associated with any. Of course, I am associated with a few companies, but no, I don't like to take commercial names. See, don't go by commercial name. Go by what is the brand, what does it contain, and what is the concentration. See, there may be 2 brands selling same hydrogen peroxide. Why you should buy one company's brand over the other company's brand? You have to understand the science. Now, what happens? For example, let us assume hydrogen peroxide you are using. Hydrogen peroxide is very effective against NCOV2. But if you look at 2 different companies, one company will be better, and other company will not be so good, their product. And why? Is because when you look at, say, hydrogen peroxide, the time for which it is effective is very less, right? The time for which it is effective. So if you want to have the efficacy for a longer period of time, the hydrogen peroxide in solution must be stabilized. So you look at the ingredients and look at whether there are many things that you need to consider. One is the efficacy, whether the efficacy is being supported by published studies. 2 is whether the contact time is less. 3 is the economic sense that it makes. Make a decision based on all of these factors. When we had started using, we were using with quaternary ammonium compound, but quaternary ammonium compound, though it is very effective, it takes 15 to 20 minutes of contact time to be effective. So we switched to hypochlorite. When we switched to hypochlorite, all the equipment started corroding. So I had to change my X-ray, I had to change the spring of my chair, I had to do everything. So then I realized, no, this is not working out. Then we shifted to hydrogen peroxide. No, in between we had done chlorine dioxide. Then we shifted to hydrogen peroxide. So now we are using hydrogen peroxide. I think it's quite effective. The way that I test it is we do some bacterial random sampling. We follow the prescribed guidelines in terms of dosage and in terms of time. That should be. But don't go by brand names.
And another question is, even this came to my mind also. Like you said that we can't be using spirit over the face shield because that makes it opaque. Then what is the alternative?
No, you can use a phenolic compound, simple soap water.
Soap water.
Soap water is fine.
Yeah, and is there any expiry date, or how long can we use N95 is another question.
So see, they will say use and throw. The determining factor for me is the the duration of usage. See, when you're using a mask, continuously you're wearing a mask for 1 hour or 1.5 hours or 2 hours, the moisture content becomes high. The moisture content in the mask becomes high. So when the moisture content of the mask becomes higher, it becomes more permeable to bacteria, more permeable to viruses. So that the water, the vapor that is there in your breath. Nowadays, what happens? We are even talking with the mask. So the salivary contamination, the moisture contamination, all that in the mask is very high. So if you are planning to use a N95 mask, use it only for procedures. After the procedure is completed, please remove the N95 mask and hang it and wear a regular mask. Whatever your surgical mask is there, 3-ply mask, you can wear that for your regular usage. Don't combine N95 mask for your non-dental, non-procedure related. So if you are doing that, then you can use the mask for a longer. As I said, you keep it once a week, you use the same mask. If you're using on Monday, use it next Monday.
That Monday, Tuesday thing, I usually keep it in an envelope and then
that's the best way to do it. That's the best way to do it.
So I think the changing cycle is also 5 days. I think that is what somewhere I came up with. You can use it after 5 days. So whatever mask I'm using on Monday, probably I'll use it after 5 days.
After 5 days, yes.
Then another question is, I think somebody is asking that can air purifier be used instead of fumigators in clinics? But these are two different things.
Yeah. So see, any purifier will means it's a filter based. So whenever you are having any purifier, that whether it is conditioning or purification, anything, that air has to pass through filter. When an air pass through filter, always we need to be a little bit careful that the filter needs to be replaced, cleaned, serviced regularly. If you don't do that, that itself after a certain point will start spreading. So I tried a couple of purifiers and I have an air quality index monitor in the clinic that measures the amount of solids in the air. Of course, this is nothing to do with COVID, but it is just to make the air a little cleaner. I realized that if you don't clean the filter very often, it itself starts throwing out a lot of dust after some time. So it is a double-edged sword. It's a double-edged sword.
We have a question from Dr. Abhijit Diogare, head of the Department of Oral Medicine. Does respirator mask poses a chance of infecting others?
Yes.
Yes.
100% yes. In fact, to such an extent that the government, in fact, had issued a directive that people found using respirator masks will be fined.
Okay. Yeah.
So yeah.
And,
there are some which are regulated ones. Those are okay. The expired air, expired air, if it is treated before it gets released, is fine. But most of the respirators only focus on the inspired air. They do not focus on expired air. So,
like how these like in Karnataka we have KPME, that is Karnataka
Private Medical Establishment.
Like it is coming up with water purification. I think the next decade or something, they will come up with air purification also. Air that is coming out of dental clinic also has to be.
Yes.
And what is the role of double gloving? This is another question. Is double gloving necessary when is double gloving necessary?
No, I will not recommend double gloving except I recommend double gloving only during prosto procedures. Prosto procedures, when we are suppose we are trimming the denture and we are doing something. So when we are inside the patient's mouth, you wear the double gloves, you do it. When you have to go back to trim it, you remove the outer glove. Then with the inner glove, you can trim it and then come back. Then wear the outer glove and then do it. So only for
I think the question is related to COVID-19 only. Is double gloving necessary when caring or treating a suspected COVID-19 patients?
No.
I think it is not a bloodborne disease, so actually it's not going to make any difference.
No, not only that, it is impossible to know which patient is COVID-19 now.
Yeah, that is.
There are 85-87% of the patients are asymptomatic. So it is possible that you may have treated your patient this morning before the webinar. That patient you saw could have been a COVID patient.
Yeah, in that case, you need to, like if it has to be done, then in every patient, you need to use double gloves or don't use double gloves in any patient.
Not practical, not practical, yeah.
Anything else to be added by other panelists, because we are all virtually sitting and not able to see everybody together. So is there any other thing which you need to be added by other panelists?
I suppose sir has explained everything in details and very nicely. Yeah.
Okay.
I don't know. It is something to do with oral medicine people, I think. All oral medicine people always will have one smile on the face. Really, and sir, a very cute smile you have.
Maybe we are, sir, basically we do not take much of tension on our heads. So
tension.
That's why.
And one thing which I would like to probably just add is related to pulse oximeter. Sir has told that pulse oximeter has to be used for testing any incoming patient. I would also say that even as a healthcare professional, we need to check our oxygen saturation every day at the end of the day. So, and one more question. This is exactly from my side only. How far is COVID specific declaration valid legally?
Oh, sir, that is the subject of a completely entire 1 hour topic. Yeah, 1 hour talk. But see, there are, sir, today I have stood in many courts, sir. I have stood over the past 20 years. I have stood in many courts, many times as accused, many times as expert witness. One thing is for sure, 90% of the time, the judgment will always be in the favor of the patient. That's our mindset of our judicial system. Always tries to take the side of the patient because they feel they are unrepresented or underrepresented and they are vulnerable. So they put the square responsibility of the blame on the doctor that you are the professional, you are supposed to take care. If you feel that the patient would have been a risk, you should not have done the procedure. Legality, yes. There are two things to this. One is negligence. And the other thing is, unfortunate instances that happen. When negligence is proven, it means there is either an intention or whether there is a gross negligence. If that case is there, then the court rules it very strictly. But if you say, so as a protocol, if you are doing any kind of procedures, you do after 48 hours a post-operative call to the patient to find out how they are feeling. So if the patient does not have any symptoms of fever, any symptoms of cold or any dry cough or any of the associated COVID related symptoms, that can be documented. And you can, if the patient tomorrow files also, you can say that we have done our post-operative follow-up after 48 hours. That's
Okay, sir. Thank you very much. YouTube moderator, Dr. Amy Thomas or Dr. Sushant Soni, are there any more questions? Are there any more questions, Palak?
No, sir.
Okay, I think.
No, sir. There are no questions from the Zoom, I think.
Okay, I think even YouTube doesn't have any questions, I guess. Okay, thank you very much for all the panelists. Dr. Shailendra Sahu sir, Dr. Abhijit Diogare sir, Dr. Babita Pawar madam, and of course our eminent speaker, Dr. Krishnaraj Ganesh Narayan. Over to you, Palak.
Sir, there is a certificate of appreciation for all the panelists. Dr. Shailendra Sahu sir, for being the panelist in the webinar. Dr. Babita Pawar ma'am for being the panelist in the webinar, and Dr. Abhijit Diogare sir for being the panelist.
Thank you.
And
thank you,
Palak, for being the moderator in the webinar. Now, I would like to call upon Dr. Rajdeep Singh for the vote of thanks.
So, good afternoon, everyone. Nice presentation from Dr. Krishnaraj sir. and from the Dr. Pramod sir, nice moderation, and all the panelists. So on the behalf of organizing committee, Department of Oral and Maxillofacial Surgery, CDCRI Rajnandgaon, it is a great honor and privilege to deliver the vote of thanks. It has been our pleasure to organize webinar on current trends in safety and infections control in the dental colleges by CDCRI Rajnandgaon, and it is also important for in this COVID-19 era to control infection, cross-contamination. At first, I would like to thank our President Sir, Nemi Sir, Vice President Sir, Buddhan Sir, Secretary Golcha Sir, and all the group related to CDCRI group. I would also like to thank Dr. Hema Srivanshi, Dean, CDCRI, for continued support and advice which give greatly help towards our successful organization of this webinar. The lecture given by Professor Dr. Krishnaraj Ganesh Narayan was informative and boost our knowledge towards infection control as general and in this COVID-19 pandemic. We all thankful to you, sir, to give our good knowledge against infection control and COVID-19. I would also like to congratulate our organizing team for putting such a good show and all supporting staff for giving their good support to conduct a good webinar. Last but not the least, I would like to thank all the faculties, PG student, UG student for attending this webinar and made it a great success. Thank you all. Thank you.
Thank you very much, everybody.
Thank you, sir.
Madam, would you like to
now
say
I
anything?
would like everybody to stand for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय
Thank you everyone for participating. Over to Dr. Pramod Krishnan, sir. Sir, any ending thoughts?
Dean, madam, would you like to end the session by any? Yeah, I think madam is muted. Okay. Okay.
Ma'am, so ma'am is on mute.
Yeah, just inform.
I would like to thank Dr. Krishnaraj Ganesh Narayan sir for this wonderful session. Like we are short of words, sir, for this beautiful session, and for once again we are thankful to you for accepting our invitation. And definitely, I hope you will be there with us next time also. Dr. Pramod Krishna sir, be in touch with sir and
Definitely.
bring him back again. And I thank all the faculties, all the students for participating in this webinar. And I thank our management and the department of our oral surgery department for arranging and successfully conducting this webinar. Thank you. Thanks a lot. Over to you, Palak.
Thank you, ma'am. Thank you all the delegates, all the faculty members to be such a support and having patience to listen to such a great lecture. Thank you to our speaker. Thank you.
Thank you.
I think everybody will get the certificates, whoever have filled the feedback.
Yes, sir. In the chat box, a link related to the feedback form has been sent. The responses will get the e-certificate for the participation. Thank you all.